Good morning, everyone. So, second day we are starting with the pediatric and fetal session. So, I invite the chairpersons, Dr. Deepa S. Kumar, Dr. Krishnamurthy KM, Dr. Praveen G. Pai, and Dr. Rajivi. We have two interesting talks. Second one is online.
Welcome to this first session of the day. ECG in congenital heart disease is often underutilized and overlooked. It gives very often even anatomic diagnosis, hemodynamic data, and sometimes it may be a harbinger of the arrhythmias which may come. So let us hear from Dr. Mukund. He was our alumni. Now he is in Manipal.
Good morning, all. Without wasting much time on the formalities, I'll thank everyone and straight away jump into the topic. ECGs in congenital heart disease in 10 minutes. This is my topic. So, ECG in congenital heart disease, what we can expect. We have to remember that ECG is an insensitive tool for diagnosis of congenital heart disease except arrhythmias. And a hemodynamically significant structural heart disease may exist without any significant ECG changes. Yet, analyzing the ECG can provide valuable insights in understanding hemodynamics as well as nature of the underlying disease. A word of caution, ECG in neonates as well as in pediatrics should be interpreted based on age. RVH is a rule in newborn. RV dominance may last up to 2 to 4 years. You may have the juvenile or even persistent juvenile pattern well into the teenage ages. Confirming situs is the cornerstone while analyzing the ECG because subsequent interpretation holds true only if the situs is normal. The normal sinus PO axis correlates with visceroatrial situs. And a mirror image of that suggests a situs inversus. Then comes the cardiac mass, whether it's a dextrocardia, levocardia, or mesocardia. The normal R wave progression from V1 to V6 suggests a levocardia. Inverse of it suggests a dextrocardia. And we have better voltages in the parasternal leads, either left or right. And subsequently, R wave tends to regress. It suggests a mesocardia. Once we establish these three things, we have to look for AV concordance. ECG in levocardia shows septal Q waves when the AV is concordant, and absence of septal Q waves may be a subtle sign of ventricular invasion or AV discordance. So this is an example of situs saltus dextrocardia. You can see that P wave axis is normal, but V1 tends to regress as you go to V6, and V3R and V4 are showing tall R waves, suggesting a dextrocardia. And this is a classical example of mesocardia. Standard leads, we are seeing good well-formed R waves in V1, V2, and V3, which regress as you go to V6. And we take the right side leads, you find the same pattern. Right sided leads towards the sternum shows good R wave voltages, which regress as we go to the right lateral position, suggesting a mesocardia. And this can be a spoiler, heterotaxy, because we don't know where the rhythm is coming from. It's right atrial isomerism. We can have two distinct SA nodes and two different PO morphologies at different times. Whereas in left atrial isomerism, we have absence of SA node and abnormal PO axis. So this itself likely poses threat to interpretation of subsequent waveforms. This is an example of left isomerism in a case of situs ambiguous, where we don't have a clear P wave, normal P wave axis, and we can't be sure what chambers we are dealing with. Further clues can be obtained from P wave as well as the PR. P wave suggests right, left, or biatrial enlargement, whereas prolonged PR or AV blocks are typically associated with corrected TGA, DRV, single ventricle AV canal defect in Epstein's anomaly. And a short PR might be pre-excitation, commonly seen in Epstein's anomaly and sometimes in tricuspid atresia. Other cues can be obtained from QRS complexes. The very interesting thing is counterclockwise versus clockwise frontal QRS loop. And apart from this, RV forces versus LV forces or biventricular dominance, or rarely the stereotypical QRS formation, all of that provide valuable clues from the ECG. This counterclockwise loop with or without left axis deviation is typically seen in 4 or 5 set of conditions: inlet VSD, endocardial cushion defect, tricuspid atresia, DRV, or the single ventricle. Other clues from QRS can be volume versus pressure overload of the right ventricle or the left ventricle. We can interpret these findings based on the clinical diagnosis that we have already made. T waves also rarely provide clues which are valuable. Like in corrected TJ, you may have upright T wave in all precordial leads due to the side-by-side ventricular relation, and DTJ may even show a taller positive V1T than V60 due to the systemic RV. Once we establish all this basic stuff, we can interpret the ECG based on the context of physiology. We have to classify, we have to have a clinical diagnosis, whether it's a left to right shunt, right to left shunt, cyanosis with reduced or increased pulmonary blood flow, or less commonly obstructive lesions, pulmonary venous hypertension or heart failure. Or sometimes the ECG itself may declare the diagnosis, like in Epstein's and corrected TGA. We'll, as time permits, we'll visit some of these physiologies, starting with left to right shunt, AST. A fairly simple clinical diagnosis, AST. This 1.5-year-old asymptomatic boy with AST findings. ECG is compatible with AST, a sinus rhythm, a prolonged PR interval, RBBB and RV forces dominant, rightward axis. This prolonged PR interval may give additional clues like Holt-Oram syndrome or a familial AST. The same AST in a 38-year-old man, clinical AST is the same, but the ECG suggests something else. It's a counterclockwise loop with left axis deviation, and we have to consider ostium primum AST. Other findings remain the same, RBB and RV forces, rightward axis. And you have a larger AV canal defect. You may also have VSD along with it, which is represented in this ECG, where you have RV as well as LV forces, the Katz-Schwarzschild phenomenon. But counterclockwise loop, though it's rightward axis, suggests it's a ostium primum or AV canal defect. And AV canal defect, the LV size is determined by the VSD or the MR. And we have pulmonary hypertension, axis can be towards the right, but still the loop remains counterclockwise, even when the Eisenmenger is established. And this yet another AST at 45-year-old. It's also simple clinically diagnosable AST, but the ECG shows that PO axis is leftward or abnormal, and this turned out to be a sinus venosus AST. This is a summary of ECG in left to right shunts, which I'll be skipping, and moving on to cyanotic heart disease. We have to classify as reduced pulmonary blood flow or the increased pulmonary blood flow or even Eisenmenger physiology, and we can look for LV versus RV dominance clinically, but ECG helps there better. So this is a 20-month-old baby with congestive heart failure and systolic murmur. So X-ray shows cardiomegaly, suggests an increased pulmonary blood flow, and clinically LV type of apex. It's fairly sure that it's a tricuspid atresia, but what can ECG add to the value further? So this shows counterclockwise loop with leftward axis, and precordial leads show hardly any RV forces, whereas LV forces are well formed, and there is a Q wave and upright T in V6 suggesting a well-filled LV. So there is a good pulmonary blood flow as suggested by heart failure clinically, and you have counterclockwise loop with left axis deviation. Importantly, RV forces are not there. What's the importance? We'll come and visit the next case, which is also a tricuspid atresia. Again, the same picture, heart failure and cyanosis in a 7-month baby, counterclockwise loop, left-out axis. And here we have RV forces seen in V1 as well as V6, apart from other findings of tricuspid atresia. Right atrium is enlarged, but left atrium usually is spared in tricuspid atresia. And when RV forces is well formed, think about coexisting TGA, tricuspid atresia with TGA, because usually in this scenario, VST is non-restrictive and RV is well developed. I'll skip this slide. And this is a summary of cyanosis with increased pulmonary blood flow, how ECG can add to the diagnosis. And without spending time there, I will go to the next commonest seen physiology, cyanosis with reduced pulmonary blood flow or the top physiology. We all of us know there's a huge list of differential diagnoses that we can make clinically when you have a top physiology. And ECG might provide so many valuable clues to prioritize from this list of differential diagnoses. So this 5.5-year-old boy had a history of CHF in infancy and saturation is 90. Obviously, it's top-like thing, like V1 is positive, and suddenly you have a sudden appearance of S wave in V2, which suggests a top physiology. And Q waves are well formed in V6, compatible with the heart failure history, good pulmonary blood flow. Both LV forces as well as RV forces are there. That's well-filled LV. But what is very interesting here is counterclockwise loop with right axis deviation. This counterclockwise loop is not typical of TOF, and along with this V3 notching and other findings which you don't have in this ECG like PR prolongation, it suggests DORV rather than TOF. So though the clinically it appears like a TOF, the ECG suggests that this is a DORV. And PR prolongation with counterclockwise loop, irrespective of axis, suggests a DORV when you have a clinical diagnosis of TOF. And LAD, left axis deviation, and LV forces happen when there is no PS. As PS or PAH increases, QRS increasingly shift to rightward. First normal, then become rightward, but the counterclockwise loop still remains. This is a 7-month baby with cyanosis and spells, suggesting a TOF physiology. And this ECG also suggests typical TOF. We have not typical RBBB, but V1 positive with a sudden appearance of S wave when you go by V2. Other atrial enlargement is not typical in TOF, and usually you get reasonably developed left ventricular forces. This is indeed a typical TOF. But when the RV outflow obstruction is so severe, like a VST pulmonary atresia is extreme form of TOF, you may not get significant LV forces as in this baby, where you don't have much LV forces. But having said that, pulmonary blood flow determines whether you will get LV force or not. If you have well-fed collaterals or PDA supplying the lung, you might still get good LV forces in VST pulmonary atresia. Look at tips. PNPR will be normal in normal usual TOF. RV dominance persists beyond infancy. Monophasic R in V1 that abruptly transits to RS pattern in V2 is a hallmark of typical TOF. And V5, V6Q and LV forces represents the pulmonary blood flow. Visiting the next ECG, cyanosis with continuous murmur. Again, we all will suspect pulmonary atresia in this case, but how the ECG helps further. You can see that P waves are unusually tall and pointed in this case, and there are deep Q waves in lead 3. What about the precordial forces? You can see that a QR pattern is in V1 and LV is well developed, as well as Q waves suggest a good pulmonary blood flow. This baby had a pulmonary atresia with intact IVS. This pointed tall P waves and Q in V1 suggest a pulmonary atresia with intact IVS with a RV that is either well formed or is pressure overloaded. Loop is clockwise, not counterclockwise, and the abrupt appearance of S wave is retained. So quick tips. Beyond early neonatal period, ECG reflects RV size in pulmonary atresia with intact IVS. A small RV will result in an adult type precordial progression. V1 negative becomes V6 positive. Whereas a large or hypertensive RV can form QR pattern in V1 with right atrial enlargement. When you have coexisting tricuspid atria, so-called hypoplastic right heart syndrome, the loop will become counterclockwise. And the axis tends to be normal, unlike left in tricuspid atresia. So this is a PA-IVS with underformed RV, post-BDG shunt. You can see the adult type of progression. There is hardly any RV forces, either in V1 nor in V6. But loop is clockwise. And this is a case of RV-dependent coronaries in PA-IVS, where you have T inversions V1 to V6. And this is a HRS, where you have counterclockwise with leftward axis. And this is another typical ECG, to and fro murmur in TOF physiology. Clinically itself, absent pulmonary valve can be guessed, but ECG is corroborative. V1 to V6, everywhere you will get positive waves. And in AV canal defect with TOF, another yet important DD, you will get the counterclockwise but right axis deviation, and LV forces will depend on how much LV is failed. So this is a way to differentiate between the TOF physiology using ECG. And finally, we'll come to some miscellaneous heart disease and signature ECG patterns like this one, another TOF physiology. Correct TJ with mild PS. You can see lack of septal Q waves in V6. Q waves are there in lead 3 because of right to left septal activation. And T waves are positive, V1 all the way up to V6, suggesting a corrected TJ. And this is a typical Epstein's anomaly where you find Himalayan P waves, a long PR interval, splintered QRS, which is positive in V1. In fact, if it is not positive, you have to consider pre-excitation. And V1 and AVR looks the same because the RV is so large, atrialized RV is so large, both are cavity looking leads now. So AVR and V1 will have general same contour of the QRS complex. And lastly, this is a 16-year-old girl with hemoptysis, had a single ventricle. You can see the stereotypical QRS complexes. All the QRS appears the same from V1 to V6. There's no transition from RV force to LV force because there's no septum at all. It's all facing a single ventricular cavity. This is my last slide. 21-day baby with heart failure, no cyanosis. And this ECG itself declares a diagnosis as Al kappa. You can see the ST elevation, 1 AVL. LVH, left axis deviation, is a hallmark of Al kappa. You hardly will find this sort of ST elevation unless you are dealing with the baby at a very young age. This is my last slide. I congratulate myself for stopping at 10 minutes.
It was excellent, Mukund. It's such a difficult topic, and you were able to do justice in 10 minutes. I know you can discuss it for hours and even weeks. Any questions?
It's not clear, sir, yet. Lack of RV out infundibulum is what is proposed as a cause.
Dr. Mukund,
Sir.
good talk. I have a doubt, not regarding diagnosis part.
Yes.
In follow-up, see, we have so many operated patients who
Yes.
in adulthood also on follow-up. Should we be taking routine ECG yearly or something?
So it depends
Or
on the
is there any relevance for any new onset widening of QRS, any axis shift, any?
Yes, sir. It heavily depends on what disease we are dealing with as well as what surgery we are doing. Some diseases have lifelong arrhythmia risk, like any atriotomy will have a risk of scar atrial flutter, atrial fibrillation, sinus node dysfunction, like in Mustard, Sennings. Any RVOT infundibular incision, like in TOF repair, is prone for risk of development of VT. We can prognosticate using QRS duration. And conduction system abnormalities can progress as part of surgery as well as part of natural history of the disease. Epstein's anomaly is yet another case where you have multiple substrates for arrhythmias. We are replacing the annulus or repairing the annulus. Our access might be difficult after that. So we need ECG follow-up lifelong in many of the scenarios.
Even in the so-called totally cured conditions like ASD, they may develop AF.
Yes, sir.
One point I would like to add, you mentioned almost everything. AV canal defect, you said RV or LV dominance is also affected by whether it is balanced or unbalanced.
Yes, sir.
Just would like to add that in tetralogy fellow, yearly follow, we always take ECG because ECG QRS duration is one criteria to decide on whether we need to take MRI for.
Older literature.
I think that follow-up of congenital heart disease now with Guch also, the yearly follow-up as well as ECG, that itself is a big topic. I think it is very difficult to cover, but that is an apt question because we will be seeing many surgical as well as other device-related as well as follow-up patients. How to proceed? Maybe you can do the talk next time. Any other questions?
Dr. Mukund, excellent talk
Thank you.
as always. So congratulations, not only for finishing in 10 minutes, but doing justice to your presentation. Yesterday, Dr. Titus sir asked the question, are there any ECG clues to multiple axillary pathways in the context of Epstein's anomaly? Are there any?
Yeah, we can, we can never be sure. But one thing is, when you have a duotromic re-entry, goes one down the pathway and comes up another pathway, you'll always get a wide QRS tachycardia. So if you have a pre-excitation and a wide QRS tachycardia that is different from that pre-excitation, that suggests a dual pathway. And rarely, if you are fortunate enough to capture this in the ECG, once you have a tachycardia transition, uses one pathway, and from a single beat, the cycle length changes as well as the morphology changes. It catches the other pathway. It's theoretical. If you happen to see that, then also you may have a clue.
Probably another clinical condition is that where you don't respond, the tachycardia doesn't respond to adenosine.
Adenosine, yes.
Yeah, then it pathway to pathway rather than AV node.
And Holter might also shows different re-entry.
Different more.
Again, you said negative will be
Yeah, that suggests a single pathway, right-sided pathway. Yeah.
If there are no more questions, thanks Mukund. Maybe
Thank you.
we'll go to the next topic.
The next topic, I think, is from online. Let me welcome Dr. Anjan S. Batra, Irvine, California. How to approach and manage fetal arrhythmias. We know this is some place where arrhythmias, and in fetus we rely more on ultrasound for diagnosis than ECGs. So ECGs are often not possible in fetus. So I think this is a very, very interesting and very new avenue. Over to Dr. Anjan S. Batra. Sir, we are audible and clear?
Can you all hear me okay?
Yeah. Shall we start, sir?
I believe the recording, my talk has been recorded, correct? You were going to play that? Greetings from Orange County, California. It's truly an honor and a pleasure to be invited today to speak at the Kerala Heart Rhythm Society. The topic I was assigned is management of fetal arrhythmias. This is a broad topic and very challenging to convey all the information in 15 minutes, but I will try my best. The objectives for this talk will include listing the common types of fetal arrhythmias, describe the treatment strategies for fetal arrhythmias, and identify side effects of the medical therapies for fetal arrhythmias. We are all familiar with the conduction system of the heart, where electricity originates in the sinus node, goes through the specialized conduction fibers through the AV node, the His-Purkinje system, and the left and right bundles. In an arrhythmia, either the electricity is originating from a focus other than the sinus node, could be somewhere within the atrium, oftentimes referred to as ectopic atrial arrhythmias, or within the ventricle, or it could be a re-entry circuit between the atrium and the ventricle, such as the common type of supraventricular tachycardia. The types of fetal arrhythmias can be broken down into three broad categories: non-sustained, such as PACs or premature ventricular contractions; sustained tachycardias, such as supraventricular tachycardia and atrial flutter; and sustained bradycardias, which would include congenital heart block and congenital long QT syndrome. So when we look at the normal fetal heart rate, the range is between 110 to 160 beats per minute. Doppler auscultation allows determination of the ventricular rate, but not AV relationship or origin of the arrhythmia. M-mode echocardiography allows visualization of the atrial and ventricular contraction simultaneously. This is an example of a fetal M mode with the atrial rate on top and the ventricular rate below it. There is a line between the atrium and the ventricle. And what we can see is there is a one-to-one relationship between the atrium and the ventricle at a rate of 141 beats per minute, very consistent with sinus rhythm. Fetal magnetocardiography. Many of you folks may have heard of this. It can be a valuable tool for monitoring fetal heart rates, and it is the closest thing we have to a fetal ECG. However, as you can see in the picture, it is a bulky and a very expensive tool which only very few centers in the United States have. If we are worried about long QT in the baby and need to measure QT intervals, then this tool could come in handy. But again, I will emphasize at the current moment, this is a very expensive, very bulky, and very limited tool that is available and that we can just all be aware of. Premature atrial contractions are the most common fetal arrhythmia. Usually, they are clinically insignificant. However, 1% of fetuses with PACs may have structural heart disease, and about 0.5% of these may develop SVT. PACs may also present with bradycardia, with atrial bigeminy with every other P wave not being conducted, and hence appearing as sinus bradycardia with every other P wave being a premature beat in the refractory period in the T wave and hence not conducting. If you see frequent PACs, the recommendations are to do weekly Doppler auscultation to evaluate for either tachycardia or bradycardia. The schematic above shows an example of a premature atrial contraction where the white arrow is, and what you can see is it fell in the refractory period, and the ventricular rate below, there was no ventricular contraction and there was a pause in the ventricular rate. Very common, nothing to worry about. So let's do a case scenario. A 36-year-old gravida 1 P0 with an intrauterine pregnancy at 24 weeks gestation presented to her obstetrician for a routine visit. On presentation, she had no complaints. In clinic, fetal heart rate by Doppler was 260 beats per minute. Bedside ultrasound was then performed and tachycardia was confirmed. You would advise the mother all of the following except: the arrhythmia is usually originating from the upper chamber or the atrium. B, the baby will need to be monitored periodically for fluid collection, also known as hydrops. C, C-section is safer than normal simple vaginal delivery for this baby. And D, the mother will need to take medications to control the baby's heart rate for the rest of her pregnancy. there are 3 correct answers and 1 incorrect, and you have to pick the incorrect choice, which is the correct choice. So I know we don't have an audience response system right now, but I'll give you a couple of seconds to come up with the answer, and then I'll give you the answer. And the correct choice here is C. C-section is not safe for the normal simple vaginal delivery for the baby. Whenever possible, if babies are in an arrhythmia, the goal should be to control the arrhythmia and then do a simple vaginal delivery. C-section should not be a knee-jerk automatic reaction. And that is what oftentimes the cardiologists working in collaboration with the obstetricians can try and achieve the goal. So fetal heart rate greater than 170 or 180 beats per minute is generally defined as fetal tachycardia. Atrial tachyarrhythmias are much more common than ventricular tachyarrhythmias. And the most common atrial tachyarrhythmia are generally the re-entry tachyarrhythmias, such as atrial flutter, which is a re-entry within the upper chamber of the right atrium, or between the atrium and the ventricle, such as an accessory pathway or Wolff-Parkinson-White syndrome, leading to SVT or supraventricular tachycardia. In atrial flutter, the atrial rates are generally a lot faster, 250 to 500 beats per minute, with a fixed atrium to ventricle conduction in a 2-to-1 or 3-to-1 conduction ratio. Now, rates of 250 to 500 would not conduct 1-to-1. And so generally you would see 2-to-1 or 3-to-1 conduction in atrial flutter, as opposed to a supraventricular reentry tachycardia from an accessory pathway, where generally it is 1-to-1 conduction, and the rates are fast, but not that fast for the atrium. So generally the atrial and ventricular rates in a reentry SVT are somewhere between 200 to 300 beats per minute. Atrial flutter can be associated with hydrops in anywhere from 7 to 43% of the cases, depends on what studies you look at. This is an example of a schematic showing 2-to-1 atrial flutter, where there are 4 smaller arrows for 2 bigger arrows, which are the ventricles, and the upper rate is recording the atrial rate. We talked about this already. Fetal supraventricular tachycardia, such as with accessory pathways, generally 1-to-1 AV conduction. Heart rate is generally 200 to 300 beats per minute, maybe paroxysmal or incessant, and associated with hydrops in 30 to 60% of the patients with a reentry mechanism. This just shows the yellow lines where the reentry is happening between the atrium and the ventricle. I'm not going to spend too much time on this, since it's a very fixed rate and a rate within 200 to 300 beats a minute. Treatment for tachyarrhythmias. Treatment is recommended for sustained arrhythmia or evidence of hydrops. Now, digoxin used to be the preferred first-line therapy for patients with reentry, and in most institutions it still is. But more and more, including the latest guidelines that came out this year, are recommending that either flecainide or sotalol be the first-line therapy over digoxin. So the American Heart Association scientific statement that came out in 2024, and I will show you the reference in the preceding slides, which you can go over in more detail, recommend flecainide or sotalol over digoxin as first-line treatment for reentry supraventricular tachycardia. Fetal drug concentration depends on a variety of factors, including transplacental transfer, fluid status of the fetus, so if they are hydropic or not, gestational age, half-life of the drug. You also want to check the 12 lead in the mother, since generally we use much higher doses in the mother to get to the fetus, and these can be associated with side effects in mothers. So get a baseline 12-lead EKG before starting the drugs and subsequently thereafter. And most of these drugs, including flecainide, sotalol, and digoxin, you can check maternal drug levels and follow them, especially for drug toxicity in the mother. So continuing with the case, plan of care was discussed with the pediatric cardiologist, and it was decided to proceed with attempted conversion of SVT using digoxin. So again, like I mentioned, a lot of institutions are still using digoxin as first line. Baseline ECG was performed and was within normal limits in the mother. The patient was then loaded with 0.5 milligram IV digoxin and then started on oral digoxin with the plan to change to oral digoxin in 24 hours. Yeah. Patient remained on continuous monitoring while this was done as an inpatient. The following morning, a fetal echo revealed fetal heart rates in the 240s, so a little slower, but still fast. But now the fetus has developed hydrops with ascites and pleural effusion, and also some decreased cardiac function. So after the echo was completed, the pediatric cardiologist recommended adding flecainide, 100 milligram twice daily. I believe flecainide is available in most countries. I'm not sure about the availability, how easy it is to get, but at least in the United States, it's fairly readily available. After starting flecainide, all of the following will need to be monitored except the mother's ECG, the baby's heart, serum drug levels on the mother, and or serum drug levels on the fetus. The correct choice is you will need to monitor all of them except serum drug levels of the fetus because we cannot do that. But we can definitely monitor serum drug levels on the mother, the baby's heart with ultrasounds, and the mother's ECG. Continuing with the case, on the third day after starting flecainide, the fetal heart rates were in the 140s. The patient was maintained on digoxin and flecainide as an outpatient, and by the following week, the fetal echocardiogram returned to normal. At 40 weeks gestation, a newborn was delivered by normal spontaneous vaginal delivery in no distress. So this was a good ending, and we hope that all tachyarrhythmias in the fetuses have this sort of an outcome with a normal vaginal delivery at the end. This is just a schematic showing you the fetal management of SVT and atrial flutter, whether they are hydropic or non-hydropic. The thing to keep in mind is that flecainide for SVT has now become first line in a non-hydropic. In the past, it used to be digoxin. If they're hydropic, you add digoxin, and if flecainide doesn't work, you switch to sotalol, and then amiodarone comes at the very end as a third line. For atrial flutter, sotalol is first line, and if sotalol doesn't work, you add to flecainide, and again, amiodarone is a third line agent for treatment of both atrial flutter and SVT in fetuses. And again, you can look at these in more detail in the American Heart Association's scientific statement from 2024. Sustained bradycardia, I unfortunately don't have a lot of time to spend on this, but heart rates less than 110. Generally, complete heart block is the most common reason for fetal bradycardia. And if they have complex heart disease and bradycardia, that can generally lead to a poor prognosis. If it's isolated congenital heart block, they don't have structural heart disease, high association between anti-SSA, Rho, and anti-SSB La antibodies, and frequent monitoring is all that's really needed in most of the times. This just shows an M mode of a patient in bradycardia with heart block. This one shows 2-to-1 block, AV block, and again, keep in mind that not just complete heart block, but also long QT syndrome can be associated with bradycardia, and oftentimes 2-to-1 AV conduction. Treatment, if they have heart rates greater than 60, the fetuses, they generally do well, and you may not need to do anything. If they have sustained heart rates less than 55, in association with complex heart disease or hydrops, they may require early delivery and immediate neonatal intervention. And postnatal interventions include pacing or chronotropic drugs such as isoproterenol. Treatment with maternal corticosteroids and complete heart block has been reported, but it will not reverse the complete heart block once it's present. Maternal treatment with terbutaline also reported, but just in general, the prognosis for fetal heart block is good, especially if they don't have hydrops or structural heart disease. Just some, at the very end, I'm going to put some references. This is for management of fetal arrhythmias, the different drugs, what class, for what arrhythmias we use them, the doses, what half-lives. These are all a good table to keep with you for reference if you need to look it up, because it's very hard to memorize all of these, but it's a good reference to keep with you when using these drugs. This is a good review paper that I wrote with Dr. Balaji in Oregon Health Sciences in the Indian Pacing and Electrophysiology Journal on fetal arrhythmias, diagnosis and management in 2019. And finally, the American Heart Association scientific statement, we wrote the guideline paper for management of cardiac arrhythmias in the fetal and neonatal periods. And it's a great reference for anybody dealing with fetal or neonatal arrhythmias to look at different tables and charts and how to manage them. With that, I'm going to stop over here. I'm just over my time, so I appreciate the opportunity and thank you very much for this. Hopefully someday I will see you personally in Kerala.
Thank you, Dr. Batra. And very comprehensive review on the management. Any questions? Yeah, there is a question, Dr. Titus.
No, you said without high drops. If there is high drops, how do you, with the arrhythmia?
He wants to know how to manage with high drops. Arrhythmia with high drops.
So we're talking about, I'm sorry, can you guys hear me okay?
Professor Titus wants to know how to manage arrhythmia with high drops.
Okay, so can you guys hear me okay? Yes, can you hear me okay?
Yes, we can hear you.
Wonderful. So, the first question obviously is it a bradyarrhythmia or a tachyarrhythmia that we want to clarify? But if it's a tachyarrhythmia, like I mentioned, flecainide and sotalol, assuming both of those are available, generally are very effective. And you want to try your level best as much as possible to try and, if you can correct the arrhythmia, the high drops will go away. So just because the baby is hydropic doesn't mean you have to do it imminent delivery. Does that make sense? So you want to try to correct the arrhythmia, the high drops is reversible, and obviously if you cannot, then you go ahead and do delivery if the baby is viable. Does that answer your question?
I would like to know what was the outcome, neurodevelopmental outcome of the baby who had high drops and then delivered normally.
Oh, wonderful question. Sorry. No, that baby did great, and most babies do great. Even if they develop high drops, if you correct the high drop, the arrhythmia, the high drops goes away and the babies do just.
Very gratifying.
How do you, what do you do when you child develops a bradycardia while treating a tachyarrhythmia?
Oh, if you develop a bradyarrhythmia while treating a tachyarrhythmia, is that what I'm hearing correctly? From medication side effects, maybe?
Yeah.
Yeah.
Yeah, I mean, I think you just, again, I worry less about the brady than the tachy, because most of the time, even, like let's say the extreme example of complete heart block, when they're very bradycardic, the fetal hearts actually tolerate it really well. So I think I'm less worried about the brady part of it. The tachy, yes, if it continues for a long period, can develop heart failure and high drops. So I think obviously at some point you may have to back up your medications if it's too much, but for most of the times they'll tolerate the brady.
Dr. Batra, a very nice presentation. How easy to get the M mode pictures as you are demonstrating in patients who are in distress?
I think it's fairly easy. I'll be very honest with you. I'm an electrophysiologist. I personally don't do it. You have people who are the fetal echocardiographers, who are the specialists who oftentimes get the echoes, and then they'll share it with us. So I think they're really good at it, and I think it's very easy for them. But I don't want to say it for them because I personally don't get echoes myself.
Any other questions? Yeah, Mukund.
Is there any role for fetal cardioversion in tachyarrhythmia?
Is there any role for fetal cardioversion in tachyarrhythmia?
You know, when you're saying fetal cardioversion, I'm assuming you're meaning with adenosine. And there have been a few case reports that have mentioned it and done it successfully, but I honestly, I would refrain from it. It's interventional because if you give adenosine, you have to give it in the umbilical cord or directly to the fetal heart. And I think the risk is far greater than the benefit. So personally, I think medical cardioversion with just, long-term sotalol, flecainide, digoxin are probably my mainstay. And I've never had a patient, at least in my 22 years of, doing this, granted it's not very common, where I have not been successful.
What about the management of ventricular tachycardia in the fetus?
Great. So that's a tough question. I mean, obviously ventricular tachyarrhythmias are much rarer, not very common. And when would you worry about ventricular arrhythmias? The most common scenario, two scenarios, right, where they would come up. One is if they have something from cardiac hamartoma, so microtumors in the heart, where they have a monomorphic ventricular tachycardia. You usually find that out after the baby delivers because when they're in utero, all you can tell is the baby's tachyrhythmic, and generally the rates are a little bit faster than the sinus rates, to like 180 to 200 beats a minute. Benign, not to worry about. The other type that I have seen that can be concerning are the ones from long QT. And it's very rare. Again, I'll be very honest with you. In my 22 years of doing this, maybe a handful of patients I've had who've had very incessant, or not generally not as incessant, but very fast ventricular arrhythmias. We've been able to manage them in utero for the most part because they generally don't last very long, even though they're very fast. Once the babies are delivered, we can see they clearly have torsades or VT that is in and out. They have long QTs. Then, at that point, you have to emergently, as soon as they're born, you have to take them. You have to not just start medical therapy, but oftentimes put in a pacemaker within the first 24 hours after they.
Dr. Bhadra, great talk. Recently, we had a fetus. Both parents were heterozygous for long QT2, and the child had a 2-to-1 AV block and intermittent runs of tachycardia. We're not sure whether it is 2-to-1 AV block or a congenital heart block, though parents were having borderline QT and heterozygous. We put the patient on beta blockers and monitored. Any other strategy would have helped that?
This is after the baby's born, is that, or before the baby's born?
Before the baby was, there
Before
were
the baby.
signs of early
Yeah.
hydrops, and it was nearly 7 to 8 months.
Well, I'm going to cheat over here, and before I give you my answer, I'm assuming the baby was born. And did the baby have long QT after the baby was born?
Yes, baby was born. Actually, immediately after birth, we put a epicardial wire and paced at higher rates. QT shortened, but there was some epicardial capture failure because of the long QT. Of course, it falls into the repolarization, and gradually we could capture 1-to-1 even at 80. Finally it was long QT2 again, homozygous.
Yeah, I mean, great case, and I always say when you have cases like these, what you did is by itself innovative. There is no literature, there are no guidelines because it's so rare. But at the same time, it's not the only case of its kind because there will be others who will come across this. I think these are the kind of case reports that are really interesting and that should be published. I don't know if you ever did that or not, but I think beta blockers are the mainstay. You could make an argument, would mexiletine have helped in this scenario? Amiodarone, we talked about the placental transfer to the baby is not very good. It's I think if you look at it, maybe 10 to 20% of what you give the mother actually gets to the baby through the placenta for amiodarone. So you have to give really high doses and it's toxic to the mother. So you have to kind of weigh the balance between the risk to the mother, the risk to the baby. Where at what point do you say, okay, we are seeing ventricular tachycardia and we need to deliver early? And I think this would be a scenario which is an exception to my talk where you would deliver on the earlier side and you would do a C-section because the risk is so high to both the fetus and the mother.
Thank you, Dr. Batra, for nice interaction with you. For the constraints of time limits, we'll have to close this session. Thank you very much.
My pleasure. And I always say, if you ever need to reach me, just email us. We have, we're all available. Dr. Balaji's talks that if any of you have ever heard on EP on Friday mornings, the last Friday of every month, please attend those. And we always say, any questions that come up, please reach any of us and we'd love to, interact. So my email is abatra, my first initial last name, at uci.edu. So that's University of California, Irvine. So abatra@uci.edu. And thank you very much.
Thank you. So we'll come to the end of this session.
Next, we have the section on physiological pacing. To chair the session, I invite Dr. Rajat Kumar VK, Dr. Haridasan V, Dr. Shanmuga Sundaram, and Dr. Padmaja onto the dais.
So good morning, everybody. I think that the next is an important topic on physiological pacing, bench to bedside, but basically dealing with left bundle branch pacing. Dr. Vijayaraman is online. Yes. The first is it is a recorded talk, but we will take questions in the end with Dr. Vijayaraman. The topic is left bundle branch pacing, concerns amongst evolving evidence. I think, if I may ask, how many of you do left bundle branch pacing as a routine? Yeah, okay. So let's get on with the talk.
Hi, I'm Pugal Vijayaraman from Geisinger Commonwealth School of Medicine in Pennsylvania. I would like to thank the organizers of the Kerala Heart Rhythm Society meeting for this kind invitation. I would like to wish them all the success in completing this wonderful conference. The topic for my presentation is left bundle branch pacing. What are the concerns amongst evolving evidence? These are my disclosures. Let me talk about the current state of left bundle branch pacing, what the limitations are, and how do we understand the physiology of left bundle branch pacing? How do we confirm conduction system capture? Can we standardize implantation and reporting? And how do we improve procedural success? These are all difficulties that are associated with left bundle branch pacing, even though it's quite popular. And the conduction system pacing nomenclature has evolved quite a bit. And while this is very good in terms of being very prescriptive and being able to explain in detail, it also adds challenges for new implanters and maybe intimidating. We have proximal his bundle pacing, distal his bundle pacing, right bundle branch pacing, left bundle branch pacing, and then there is possibly fascicular pacing, left ventricular septal pacing. And these are all somewhat defined. However, the left bundle branch pacing success, depending on what your endpoints are, varies from 50 to 95% in terms of confirmed left bundle branch capture. Often the endpoints are unclear and different centers use different endpoints. And we have issues with acute and sometimes late lead dislodgement, concerns for lead perforation. And how do we have clumped everything together as left bundle branch area pacing. And when do we define LV septal pacing versus left bundle branch pacing? And can we uniformly use the terminology, whether it's proximal or distal? What are the issues associated with tricuspid regurgitation while doing left frontal branch pacing? And then there's concerns about long-term issues of potential for lead fracture, which a lot of it we don't know, although early evidence is somewhat concerning. And there's some concern for lead extraction, and all these need to be addressed as we gain more evidence for left frontal branch pacing. While his frontal pacing, it's very clear regarding the procedural endpoint. We can confirm his frontal capture. We can clearly see when there is left bundle branch block correction or right bundle branch block correction. And the criteria have been laid out, and more than 95% of these patients who undergo his frontal pacing, it's very clear that you can define them well. And so it's not as much of an issue. However, left bundle branch pacing, confirming left bundle branch pacing capture can be very nuanced and challenging. And unless you pay close attention and very rigorous, this gets muddied very quickly in the name of left bundle branch area pacing. And it's important to understand many of the criteria that were developed initially, while they were highly specific and while trying to make it simpler, the criteria developed were based on normal baseline KHRS and in patients without structural heart disease or without left bundle branch block. And the left bundle branch capture criteria may not always do well in patients with septal scar on those with diffuse conduction disease. So you have to understand what the issues are and then accordingly approach that. And this is the EHRA consensus statement on how do we define left bundle branch capture. While this was defined as most clearly left bundle branch pacing versus likely left bundle branch pacing versus clearly LV septal pacing. And even if you look at the criteria for left bundle branch pacing, and we see KHRS transition for during threshold test to have non-selective to LV septal pacing or selective left bundle branch pacing, as defined here, as the gold standard for left bundle branch capture. In different studies, it varies from 30 to 90% that this can be demonstrated. In my experience, it's probably about 75 to 80% of the time you can demonstrate this clearly. And while this is a good criteria, there are situations where this may fall apart, and you need to understand that. And then the next criteria using V6 RVA peak time less than 75 milliseconds or less than 80 milliseconds patient with left bundle branch block or white KHRS at baseline. This criteria is not, while this number may be specific, but there are many scenarios where this may fall apart. And so that is important to understand. And similarly, the V6 to V1 interpeak interval. And program stimulation, many centers don't do them. It's difficult. And then when you go to likely left bundle branch pacing, again, there's a lot of these criteria have higher sensitivity but poor specificity. So that gets even challenging. Whether it's really LV septal pacing, it's mid-septal pacing. So those become difficult. So I recommend that people try to make an effort to clearly define them as best as possible. So I want to here is a patient with complete heart block and cardiomyopathy who's undergoing left bundle branch pacing, initial lead placement and doing threshold testing. I want to pay attention to a couple of the criteria. There is a change in peak R wave time as you lower the output, and clearly change in KHRS morphology, whether you look at any of the leads, V1 and V4 to V6, all of them show clear changes in morphology. Peak R wave time is prolonged, and you can also see that the peak R wave time in V1 is changing, and it's wider. And so you have the scenario where V6 to V1 interval is 45 milliseconds. That would be highly specific for left bundle branch capture. On the other hand, peak R wave time is significantly prolonged here. That makes it even more challenging. And this is too long. Is it really left bundle branch capture? And more on top of that, You also have a change in local electrogram suggesting this possibly is selective capture. However, when we paste at a higher output, you can see that peak airwave time is much shorter, and you have V6 to V1 interval of 38 milliseconds, which is in the intermediate criteria. So, but this clearly is the left bundle branch capture. And these two changes are in a patient with septal scar and different myocardial fascicles being captured at different thresholds and leading to different pattern of activation. So we've got to be careful about that. If you look at R wave peak time, assuming you place the lead in the proximal septal region, not in the posterior fascicle, not more apical location, in that scenario itself, there is a lot of crossover between septal pacing and non-selective left bundle branch pacing. Well, the shorter the number, the specificity goes up, but the sensitivity goes down significantly. Even though the criteria claimed 100%, I'm part of this paper, 74 millisecond. I have numerous examples where you can have peak R wave time with his bundle pacing in the low 70s. So left bundle branch capture should be even lower than that. And this number is about 80 milliseconds in wide QRS and even much greater overlap in this criteria you can see. And as you can see, 101 millisecond gives you the maximum sensitivity specificity, but if you want a greater specificity, that number is less than 80, and even this may not be accurate as I will and we talked about the V1 to V6 interpeak interval. Again, there's a huge overlap, and 33 milliseconds seems to have a good area under the curve. But again, we don't have 100% sensitivity specificity for this criteria. And so you cannot use it as an absolute criteria. You have to use it as an adjunct criteria. Here's a patient with the left bundle branch block cardiomyopathy, and here's left deep septal left bundle branch area pacing. Have a peak R wave times of 75 milliseconds. And if we look at the LV activation using unipolar vision wire recording, you can see the QLV is 120 millisecond. And while STIM2, the LV activation time is shortened, if you add conduction time for left bundle branch pacing, it may be a little shorter. But you can see that it's only about 20, 30, 40 millisecond narrowing of the LV activation times. However, in the same patient, when we paste the His bundle and you have selective correction of the left bundle branch block, the His to LV time of 160 milliseconds is shortened to 97 milliseconds. That's about 63 milliseconds narrowing achieved in the LV activation time. And you can see when there's no correction, that goes to about 157 milliseconds. So you would get 60 milliseconds narrowing of QRS. But look at peak LV activation time, it's only about 70 milliseconds. So pacing from a proximal site gets us 70 milliseconds. So left bundle pacing should be even further downstream, and it should be much shorter. So in the previous example I showed you, there was only LV septal pacing, and we didn't achieve maximal QRS or LV shortening with that. So if you use arbitrary criteria, then you may not have achieved. So it's important. And the reverse side of it, in patient with conduction disease, here's a patient with long conduction time, left bundle to QRS interval of 95 milliseconds, HV interval of 125 milliseconds. And pacing bipolar at high output, you have this QRS morphology. And at a lower output, you lose anodal capture with a change in morphology. V1 does not even have R prime activation. QRS is fairly long. And as you come down on the output, you can pay attention to the local electrogram releasing the His left bundle activation, suggesting that this is primarily LV septal pacing. And there's no difference between LV septal pacing and when there's left bundle capture, because the conduction system is diseased. As shown here, the lower output, you have selective capture of the left bundle with a long conduction time. So capture of the left bundle did not contribute to the QRS morphology here. So it was primarily LV septal pacing with a lot of conduction delay and may not be very good. This patient should get at least biventricular pacing. Here's another patient with mixed conduction disease. So you have QRS duration of 230 milliseconds. His bundle pacing, here is non-selective his bundle pacing, and then selective his bundle pacing. There is partial correction, peak activation time is shortened, and then here you have selective capture with minimal changes in QRS morphology. So it's a fairly wide QRS, so this patient has mixed conduction disease. And what do we do when we do left bundle pacing? So I'm looking at QLV, I have an LV lead, and pacing at a high output, you see there is shortening of QLV, and it's about 180 milliseconds here. And that, if you exclude some conduction system capture, so as you see in lower output, you have selective capture, but there is isoelectric timing of 50 milliseconds. And if you take QLV, when there is left bundle capture, compared to native rhythm, there is about 80 milliseconds shortening with the left bundle pacing. So even though the pace QRS is wide, LV activation is somewhat decreased by this approach. And then this is adaptive AV delay adjusted lot CRT, left bundle plus coronary sinus pacing gives you the maximal QRS narrowing. And this is the patient with baseline QRS, and when you do lot CRT, is significantly narrowed, and look at the echocardiogram, severely dilated LV and fairly wide and dysfunctional, dysynchronous LV. And this is within 3 months after lot CRT. LV function normalized and EF completely improved. So in this patient, the combined approach clearly helped in terms of maximizing electrical resynchronization. So why is this important? This is a study that used slightly established criteria, but not clear which of the patients had left bundle branch capture, because the criteria we've established is not perfect. And all you needed to have is QR morphology in V1 and any one of these criteria. And if you have LV activation time less than 80 milliseconds or interpeak interval, I showed you many examples where you don't have left bundle branch capture despite having this. And so despite showing that, they showed a difference in clinical outcomes of heart failure, hospitalization, all-cause mortality in a series of patients comparing left bundle branch area pacing with YV pacing. So if you're strict about left bundle branch capture, and if you place the lead in a proximal location, there's a good chance that you have greatest electromechanical resynchronization with benefit. And so if you settle for LV septal pacing, you may not achieve better outcome than biventricular pacing, and sometimes even worse outcomes. And this study showed there's some limitation. They say that the QRS duration is 117 milliseconds, but they didn't measure from the stimulus, measured from QRS onset, which is also arbitrary. So we got to be very strict with how we define and present our information. So my concern about the limitations is that current definitions of left bundle branch pacing may not include all clinical scenario. Assessment of left bundle branch capture is more challenging, and assessing bundle branch correction in left bundle branch block is even harder. And then you have to discuss how do we measure QRS duration and how much narrowing is necessary. Is QRS narrowing an acceptable endpoint in left bundle branch pacing? In many cases, it's not. And do you measure from stimulus to QRS end or presumed QRS onset? I would strongly urge you to use stimulus to QRS end for the sake of uniformity. And understanding that peak LV activation time, or R-wave peak time, is a surrogate at best in assessing left bundle branch capture. Don't settle for a fixed number. You individualize for the patient. And also based on where the lead is located. If you're more apical and posterior, your R-wave is not a perfect assessment for peak LV activation time because you have a deep S wave. And the nadir of the S wave may be a better surrogate for assessing LV activation time. And remember, in patients with IVCD, those on class 1 drugs or amiodarone, the QRS duration and activation times can be longer, even with left bundle branch pacing. So traditional numbers may not work in your favor. And then there are newer tools for left bundle branch pacing. As more and more stylet-driven leads are being used, you need to understand the difference between the leads and weaker links in some of these leads, especially Boston Scientific and Biotronic leads, where there's a significant flex point between the tip and the ring electrode, while the Medtronic lead and the Abbott leads have more of a stiffer thing. Whether it's a benefit or a disadvantage needs to be studied carefully. While the stylet-driven leads are better for easy torqueability, and you can manage continuous spacing during fixation. And the disadvantages are the larger diameter, there's risk for entanglement of the helix, potential for helix fracture, and the tip to ring fracture possibilities. Cases have been reported. The studies have looked at both stylet-driven leads and lumenless leads to assess long-term durability. But again, the testing may not be as accurate as clinical stress that happens, twisting motion in the septum, and the use conditions at the time of implant, because we do see cases of lead fracture, and during extraction, some of them tips get left behind, and these needs to be addressed. So in summary, accurate confirmation of left bundle branch capture is critical to facilitate acceptable procedural endpoint. Long-term outcomes of left bundle branch pacing, both clinical and the safety outcome, needs to be studied carefully so that we don't get too deep into this before realizing the negative effects of left bundle branch pacing. We do need dedicated tools, not only delivery tools, but leads that are designed to withstand the stress that they undergo during left bundle branch pacing and during long term. I think all this will be necessary to steer in a clear path of successful left bundle branch pacing and improved outcomes for our patient. And thank you very much.
Well, thank you for that excellent talk. I'm sure there are a lot of questions from the audience. Dr. Vijayaraman is online, is that?
Yeah.
Yes, yeah. That must be evening with you. What time would that be?
It's well past my bedtime.
Okay, so I'll start the question. See, assuming that there is left bundle capture, isn't QRS duration a better parameter for assessment for efficacy? And translating that, when you do a CRT or a lot, what is the threshold at which you cross over to a conduction, a left bundle branch pacing as well?
Yeah, so his bundle pacing is very clear when we have QRS narrowing. With left bundle branch pacing, I don't believe in QRS width as a guide. So is there a lot of echo? I'm sorry.
No, everything is fine here.
Oh, okay. So with left bundle branch pacing, there's always much more QRS widening that you see than with his bundle pacing because of RV conduction delay. On the other hand, there's not much difference between LV septal pacing and left bundle branch capture in terms of QRS width. So that's not often a good criteria to help us decide whether you have successful left bundle branch capture. So that's a challenge. So my primary aim is to confirm what type of conduction disease you have. If you have clear left bundle branch block that's correctable by his bundle pacing, or that shows mixed disease, then we use lot CRT. If you want to use a rough marker of peak LV activation time, then anything more than 90 to 100 milliseconds in the setting of left bundle branch capture is not acceptable So either you do biventricular pacing, or if you have better narrowing with LOT CRT, then I would use LOT CRT.
Yeah, any questions from the audience? What about the reverse? Assuming that you're gone for a CRT pacing and you put in the LV lead first, at what QRS duration would you put in a left bundle pacing?
That's a tough question because we have changed our strategy to hit conduction system first. But in the early days when we were doing biventricular pacing, well, QRS duration, while you get narrowing, we know it's helpful. When you don't get narrowing, we don't know if it is not good or. So we often try to choose QLV, RVLV times, location, basal, lateral wall. So those were our criteria that we were using. And as we moved on to conduction system pacing, if we don't have a significant RVLV separation or short QLV, then we move on to conduction system pacing. So now it's easier for me on the reverse because once I understand what the disease is, then I choose what's the best option for that particular patient. If it's true IVCD, I primarily go biventricular pacing. Occasionally, if I find that I can use his or left bundle to optimize, then combine LOT CRT or hot CRT in those patients.
Shan? Dr. Shanmugam is here with us.
Good morning. Sorry, good night, sir. I think probably we'll be going to our bed, I think. Yeah, so so just to again ask, so when are you going to put an additional CS lead when we are doing a conduction system pacing based strategy, or when we are going to switch over from a dual chamber to a triple chamber CRT? Any specific numbers you are looking for apart from LVAT? When we are going to put an additional CS lead for a patient with requiring a CRT?
Yeah, so in the US, in patients who need CRT in the LV ejection fraction less than 35, often they get an ICD. So I have to choose either it's a CS lead or a left bundle branch pacing lead. So the number of times I add CS lead on top of a left bundle branch pacing lead is about 5 to 10%, the LOT CRT.
So one last question. What is your, in the US, what are the percentage of left bundle branch pacing? What percentage of people accept it? This audience about 25% or 15 to 25%.
Oh, okay.
Yes.
So currently from what I see among Medtronic lead, we can track it by the 3830 lead usage. I think current is about 40% of all pacemaker implants or left bundle branch area pacing. His bundle is probably 1%, and primarily in my center. And then the infiltration of styler-driven leads is kind of hard to quantify at this point. But if you ask me what percentage of physicians do true left bundle branch pacing or left bundle branch area pacing, maybe less than 50% of those who are doing it.
Okay, thank you. Thank you so much for that excellent talk. Since we are running short of time, we'll go on to the next one.
Sure, thank you.
For the next talk, let me welcome Shanmuga Sundaram, who is the pioneer in the field of this conduction system pacing in our country. And he's doing a lot of original research work as well, and for that he's being recognized recently. So he'll be talking on tips and tricks. So over to Shanmuga.
Thank you, sir. Once again, I'd like to thank Kerala Heart Rhythm Society for giving me this opportunity. So my job is to discuss about the tips and tricks for implanting the left bundle branch pacing lead. Imagine a scenario if you are coming across a scenario like this, I would rather like to re-implant the hand back in the upper limb rather than the lower limb. Similarly, if you come across a disease in the conduction system disease, whether it is partial or complete, resulting in left bundle branch block, right bundle branch block, or complete heart block, I would love to implant the lead back in the conduction system, either in the distal east bundle or in the proximal left bundle, rather than in the RV myocardium. Though the procedure is very simple, but the definitions are not, so we have a lot of different terminologies to understand when you're talking about left bundle branch pacing. So LBBP, left bundle branch pacing, indicates capturing either the proximal main trunk of the bundle or one of its fascicle along with the septal myocardium. But as a broader terminology, the European consensus statement, they have given left bundle branch area pacing, which includes not only the bundle or fascicular pacing, but also the LV septal pacing. So we need to have tools. The procedure is essentially the same as a dual chamber implantation, but for the additional tools, we are deploying the lead far away from our conventional site. So we need to have dedicated catheters and dedicated leads for performing the left bundle branch pacing. So the catheters can be of fixed curve shape or it can be of a deflectable one, but more commonly we use the fixed curve sheets. The leads can be the lumenless 3830 lead or the conventional styler driven leads. In the lumenless lead, already the helix is exposed. It is otherwise called as an open helix lead. But for styler driven leads, we need to expose the helix first before getting into the septum. So that is the one concern with the styler driven leads, the chance for helix retraction while implanting or after the procedure. So we have now dedicated helix locking tools which can lock the exposed helix so that it will not come back during implantation. That was considered as one of the major drawbacks of using the styler driven leads. So whatever the lead we are going to use, whatever sheath we are going to use, the ultimate aim is to get into the left conduction system. So understanding the cardiac anatomy, fluoroscopic anatomy is very important. Always start in right anterior oblique view where the cardiac conduction system will be looking like this. So it's our practice to get two catheters from the groin. So one will be in the his location, the second one will be in the RV apex. Imagine, just understand the identification of the his bundle solves almost 50% of the procedural complexity. So we need to go little below the his bundle. You can see the his bundle dividing into right bundle and left bundle, and the left bundle in turn divides into anterior fascicle and posterior fascicle. The first job is always to identify the his. Then anatomically, we can identify the target zone by going 1 to 1.5 centimeter below the distal his signal towards the RV apex. That's most easiest way of identifying the target site. For double confirmation, we can use the electrocardiographic marker. Pace from the right side of the septum. You have to have a W pattern in lead V1 along with the discarded QRS complexes in AVL and AVR. The lead 2 will determine whether you are going to capture the left main bundle or the posterior fascicles. So if the pre-implantation QRS having a predominantly positive lead 2, that means that you will be capturing the main trunk. On the other hand, if the RV septal pacing is going to generate a negative lead 2, you will end up in capturing the posterior fascicles. So identify the target site, deploy the lead in LAO, so that gives us a good view of the lead traversing the septum. Try to have a dry hand, so I always start with 2 powdered gloves and remove the outer glove just before deploying the lead so that I'll be having a single powdered glove in my hand. Both your hand and the lead should be perfectly dry so that you can have enough grip to give rapid rotation. So you can see the second operator is holding the sheath. The sheath should be in 4 o'clock or 5 o'clock position so that inside the heart will be well opposed to the septum. And rapid rotations either from the end of the lead or closer to the sheath will help. So this rapid rotation will generate PVCs because of the irritation of the myocardium. And once you track the PVCs, you can see the morphology, just see the lead V1 changes from QS to QR. That means that as the lead traverses from the right side to left side of the septum, the QS morphology changes to complete or incomplete right bundle branch block delay pattern as the lead reaches the left side of the septum. So once you get a QR pattern or RBBB delay pattern, you can stop giving further rotation. Once you get a specific PVCs of M morphology in lead V1, so these are the PVCs which are actually coming from the left bundle, we call it as an M beat. So that means that almost you have reached the target site. Any further rotation is going to produce perforation. So this M beat can be taken as a marker of endpoint for giving further rotation. So once you are done, the next job is probably to confirm the capture of the left bundle. So this is how we usually perform the procedure for the lumenless lead. But for stylo-driven leads, it should be a controlled rotation, because rapid rotation many times will end up in septal perforation. So we always go by doing a continuous pacing strategy. So in stylo-driven leads, we always have the stylet at the other end so that you can pace continuously. Give controlled slow rotation, and you can see the QRS morphology again changing from QS in lead V1 to QR in lead as the lead reaches the LV side of the septum. So again, taking that QR or RSR as an endpoint, the next job is to confirm the capture of the left bundle. So procedural success roughly is around 93%. From this our single center experience, around 93% will be able to capture the left bundle. The main thing is, what are the reasons for procedural failure? The most important thing is inability to penetrate the septums. That happens in almost 3% of the patient. And despite penetration, another 2%, we could not confirm the left bundle branch capture. It's all LV septal pacing. But the interesting thing is, almost in 3.5% of the patient, the septum was cheesy, so we could not deploy the lead and hold the lead there convincingly to have a consistent capture of the left bundle. So we know that the key for successful deployment is going to be the septal behavior. So we analyzed the septal behavior of close to 300 patients who got the left bundle branch pacing lead, and we came out with 3 different septal behavior. The type 1 is the most common septum which we often encounter. This is irrespective of the underlying LV function. The type 1 behavior, where you can give rapid rotation, the lead will have a continuous but slow progression inside the myocardium. It's something like a screwdriver effect. And this holds better inside the ventricular septum, and the long-term stability of the lead is much, much better. And fortunately, this is the most common type of septum we encountered. And type 2 is a cheesy septum. This is often seen in patients with normal myocardium, and this predominantly almost 9 patients we had, which was around 3.5%. Predominantly, these patients had a AV block and 6 sinus syndrome as their etiology. You can see just a couple of rotations, the lead was just crossing across the septum, landing up into the LV cavity because of the altered texture of the septum. The type 3 is a scarred septum, which is the most common septum which we encountered in ischemic cardiomyopathy patient. Because of scar, the septum will be totally necrosed. You will not be able to penetrate the lead inside the septum. So even if you penetrate, you may not have a surviving left bundle fibers to produce synchronized activation. So once you enter into that area, the next thing is to look for the potentials. The potentials can be manifest, meaning that immediately after deployment you'll be able to see, or it can be concealed within the negative current of injury. So you have to wait for 5-10 minutes to get the potential out. In patients with a baseline left bundle branch block, you may not see the potentials. You may have to do hysterective pacing to unmask this potential. This is very important in patients with LBBB morphology, where you may have to do a hysterective pacing to bring the potentials out. So RV peak time is probably the easiest and most important criteria to confirm the capture of left bundle. So here we'll be pacing at high output and low output to look for the RV peak time. This will simply say how early your LV free wall is getting activated. So if you are in the left bundle, irrespective of the output, whether you are pacing at a high output or low output, the RV peak time will be short and constant. On the other hand, if you are little away from the left bundle, at high output you may be capturing the left bundle, so your RV peak time will be short. But once you reduce the output, you may lose the capture of the left bundle, so your RV peak time will be prolonged. So if you have a scenario where the RV peak time is short at high output, but prolonged at low output, you may have to give additional rotations to get into the left bundle. So this is probably the quickest criteria which can be applied for confirming the capture of left bundle. Output dependent ECG transition. The previous sessions I was talking about the output dependent ECG transition in conduction system pacing. The principle is that you are capturing 2 different substrates with a single pacing lead. So these 2 different substrates will have a different electrophysiological property in terms of conduction velocity and refractory period. So at one particular output, as you reduce it, there will be a loss of one substrate, so there will be a change in ECG morphology. So you can have, these are the different possible ECG transitions which you can have. So in patients who are undergoing left bundle branch pacing, the two most commonly seen transitions are non-selective to selective to loss of capture, or non-selective to septal capture to loss of capture. This is one particular example where you can see as the output is reduced, the QRS morphology is changing from non-selective to selective to further septal capture and ultimately resulting in loss of capture. So you can see the change in local electrograms. You can see as the capture changes from non-selective to selective, the local electrogram is getting pushed away in the lead electrogram. But the most importantly, you can see the change in the QRS morphology. Another important thing which we often see is the retrograde conduction of the His signals. So when you have a conduction system capture, you'll be able to record the retrograde His potentials. This can be seen in non-selective capture as well as in selective capture. But when you lose the conduction system capture, the retrograde His will not be there. So the last beat was just a simple septal capture. You could not see any His potentials there, unlike in the non-selective and selective capture. So just to simplify the criteria, so these are the endpoints for giving further rotation. This is probably the most commonly asked question, when to stop giving further rotation. So when you have a non-selective to selective capture, that means that you're right on the top of the left bundle, further rotations will penetrate. Short and constant LVAT, M-beat, unipolar impedance nearing 450 ohms. So anything less than 450 ohms will tell you that you have perforated inside the septum and getting a concealed potential. So these are the possible endpoints for giving further rotation. And among this, we would consider this non-selective to selective as a gold standard marker for confirming the left bundle capture. So just stop with this slide, a most simple criteria to confirm the capture of left bundle. So rather than going for a multiple complex criteria, if you are understanding it and using it on a day-to-day practice, almost 95% of the time, you know that you are entering into the left bundle. So one is a pace QRS morphology of QR patterns. We know that we are pre-exciting the left bundle. So we'll be generating right bundle branch delay pattern in the surface ECG. So that can be considered as a major criteria. Apart from that, one of the other minor criteria, if it is satisfying, that confirms that you are into the left bundle. So one is short and constant LVAT, which can be quickly measured at 8 volt and 2 volt. The second one is output dependent QRS morphology transition. So just reduce the output. If you could see two different QRS morphology, that confirms that you are into the conduction system. Getting the left bundle potentials may or may not be in some patients with a baseline left bundle branch morphology, you may not see the potential. And in majority of the patients with an antegrade conduction, these potentials can even be far field. So this cannot be taken as a valid proof that you are capturing the conduction system. But the other criteria, 3 criteria, will help us in confirming the capture of left bundle. I'll stop here. I'll be happy to take questions.
Thank you. Thank you, Shan. Dr. Shanmugam was a resident with us and then a fellow. And of course, of recent, he has got the Young Best Researcher Award from KHRS. So we are proud, Shan. So I would just ask one question which I asked earlier. And now, assuming that you are going to take a patient for a CRT pacing and you put on left bundle, so at what QRS duration would you put in a CS lead?
We rather go by LVAT rather than the QRS duration, because the QRS duration is variable depending upon the site we are pacing. So any LVAT, if it is short and constant, especially if you are capturing the proximal bundle, so anything less than 100 milliseconds we will accept. We'll use the native AV delay to further reduce the QRS duration. Anything more than 100 milliseconds, it's always our practice to add a CS lead. So LVAT probably is a good marker to go for rather than a QRS duration.
The QRS duration is actually a correlate of LV peak time. So in short, I think to make things simple, because most people who do a septal pacing and who would by chance have a left bundle pacing, they would certainly look for a right bundle W pattern. And then next what they would look is a QRS duration. So what is the optimum QRS duration that you should aim when you do a conduction system pacing?
So when it comes for an alternative for CRT, so the wide right bundle branch delay pattern created by this left bundle branch pacing, we have seen almost 150, 160 milliseconds QRS generated by the left bundle branch pacing lead with an LVAT of 90, 95. But when you do an AV delay optimization, this will automatically come down to 110, 120 milliseconds. So rather than aiming for, again, the most important point is to look for a better LVAD, which is a direct marker of LV free wall activation rather than the QRS duration, because the QRS duration here will be affected by the right bundle branch, right ventricle delay also, especially if you are capturing the left bundle selectively. Almost the terminal 20-30 milliseconds of the QRS is going to be that RV activation pattern. So that is again going to add on to the overall QRS duration. So it's always better to go by LVAD, which can be quickly measured with or without EP system. And probably in the future, we can have criteria based on the limb leads as well. So that is probably the quickest way to decide about adding a CS lead rather than the overall QRS.
That is fine. I'm not talking about the addition of CS lead. For anybody who does a conduction system pacing for a non-CRT indication, what is the optimum QRS duration that you would like to have?
QRS duration again varies, sir, because it can be an incomplete or complete right bundle branch delay based on the QRS duration varies. So QRS duration should not be taken as a criteria or endpoint for doing a conduction.
One thing, there are studies which shows that depending on the upper septum or basal septum or epic septum that you face, LVAT also has been.
Yeah.
So how do you account that LVAT will be the criteria on which you base?
Yeah, so because of that only there was none of the criteria had given any specific cutoff number for LVAT. Based on the location of the conduction system, the LVAT varies. Yeah, so if you are in the his bundle, you are away from the free lateral wall of the left ventricle. If you are down into the conduction system, you are closer to the LV free wall. So the LVAT will be very short, but that will be compensated by the prolonged S wave. The S wave duration will increase. So the numbers which are given are like 70, 80, all these are based on...
How do you base it on absolute value of LVAT?
No, you should not take any absolute value, rather you have to go by short and constant number. Because if you are in the upper septum, if you are in the basal septum capturing the main bundle, then that number of 75 and 85 will hold good. But when you come down, it even can see an LVAT of 45, but with a QRS duration of 130, 140 milliseconds. So it depends on the position of the lead in the conduction system.
You see, the LVAT or the RV peak time is basically a conduction time. So it basically reflects the conduction velocity and thereby the conduction time. Yeah, one last question. So that,
when do you the septal scar?
Yes, sir. Any patient coming for device will get a cardiac MRI in our hospital. So it's easy for us to get a cardiac MRI. If you find a transmural scar in the basal and mid anterior septum, inferior septum, if you do go to that AAC model, overlapping zone of 2 and 3 and 8 and 9. So basal and mid inferior anterior septum overlapping zone. If you are getting a transmural scar, then the successful procedure, it will not be able to deploy the lead successfully. It's better to go for a conventional strategy by BIV rather than by left bundle branch pacing.
Thank you, Shan, for that excellent talk. Since we are running short of time, I'm sorry for having taken this amount of time in both the last two talks, but then these were very important ones. So, Dr. Abhilash, conduction system pacing versus CRT, the same questions that are getting extended. Yeah.
Good morning, respected chairpersons, my teachers, and dear friends. I think I should thank the KHRS team and Boris Sir Vijay for giving me this opportunity to be in this session, in which most of my slides are going to quote the other two speakers of the session. So, indication for CRT in heart failure is straightforward. I need not spend much time on that. It's a bit complex algorithm, but we know it. Then, there are limitations for the CRT. One, it's a non-physiological modality because the LV lead is going to be based on epicardium to endocardium. There is 1/3 non-responder rate, and limitations like when you don't have a good coronary venous anatomy, there are high threshold issues, and of course, phrenic nerve stimulation can limit. Limited applicability of biventricular pacing. Say non-LBUB, the non-responders are more. Prevention of pacing induced left ventricular dysfunction, again, you need more data. So there are some subset where biventricular pacing will not work. Then there are the alternative to conventional CRT. That is my talk today. We have two options, his bundle and left bundle area pacing. Of course, we have the further modifications of it, like we have the HOT CRT, LOT CRT. I will be restricting essentially to the the initial two one, his bundle and left bundle. An ECG looking like this, becoming so narrow and beautiful like this with these three modalities. First one is the conventional, second is the his bundle, and third is the left bundle area pacing. Our last 3-4 years has been fascinating with respect to this technology and the new science. And it's all started with the his bundle pacing. It is, of course, but more technically challenging. You need an EP lab, you need to record the his potentials. And again, the other practical issues, like you are almost placing it between the atrium and ventricle. So you have the R wave sensing issues, you have higher threshold at implantation. There's many mechanisms. I'm not going into it, but of course, this resulted in more battery drainage, more replacements, unacceptable delayed rise in thresholds. It's seen in up to 10 to 11%. Then the left bundle area pacing came up, which has a larger area to target, more distal correction in conduction, and the thresholds are more consistent and low. But we can see we used to keep one pulse width for the his bundle, whereas it's same as any other pacemaker for left bundle, 0.4 pulse width, and consistent myocardial backup pacing. If the left bundle fails, you have the ventricular capture there, unlike the his bundle. No requirement for backup pacing leads, and AV nodal ablation, if needed, a typical example would be an AF. It can be done safely because your lead is distal to it. Then all these are theory. What is the evidence in clinical practice? I will divide into certain subsets. As an alternative to CRT, we have evidence and conditions where high rate of pacing is anticipated with borderline LV function. Typically less than 40, we anticipate more than 40% ventricular pacing, and upgradation in pacemaker-induced cardiomyopathy, AV junction ablation and pacing, and in special groups like non-LBUB, and also in right bundle branch block, functional MR. Most of the data has come from Shanmuga Sundaram and Pugadendra sir. I will come to it. And this one case where we have done heart failure alternative to CRT, you see the beautiful ECG from the left upper corner to the right on follow-up. It remains same, narrow on follow-up with just 2 leads. So simple, right? Then it's not theory. We have enough data now. It started from a Chinese team, then reproduced by Pugadendra sir and Shanmuga Sundaram from different studies, and one study from Australia where I could also be part of. Then that is the evidence so far with respect to CRT in heart failure. Conditions where high rate of pacing is anticipated with borderline LV dysfunction, which is not a usual CRT indication. It's a borderline LV, but when you have a similar technology device, why not go for it? So we have data for that with 35 to 50% EF. Again, heart failure technically, but not the typical CRT indication where we have data. And then there are case reports or even data come about pacing induced cardiomyopathy where you can try left bundle pacing. LBB pacing with AV junction ablation, that is again not a rocket science to understand the utility. Then there are special groups where CRT is not routinely recommended, non-LBB groups. We have data from Shanmuga. Then other special groups like right bundle branch. Then we have data coming up. These are, of course, these are all not large numbers, but it's an exciting field and exciting things to see. It's much easier to do a left bundle pacing than a CRT. Of course, we know the technicalities. Then functional resuscitation in cardiomyopathy. We have case reports or even short series telling the utility of left bundle pacing. This is the group study with left bundle area pacing in coronary venous lead failure or non-responsive to biventricular pacing. Other options are limited for these patients because already CRT has failed, where the left bundle can actually improve. We have the complex devices like YCRT and all for this subset, but it's very complex because you have an endocardial pacing lead, you have to place an LV, but this is much similar compared to that. Then these are the evidences so far. That's the first part of my talk. Then the second thing is what are the guidelines? Even though we have getting more and more knowledge about the thing, Class 1 recommendation currently HRS 2023, but these updates can happen with some of the studies came after these guidelines, so updates can happen. Even now, for the typical case, like EF less than 35%, LBUB, QRS more than duration more than 150 milliseconds, Class 2 to Class 4, the level of evidence with Class 1 recommendation is for CRT. But we know there is a subset where you not have a functional or anatomical good coronary sinus lead position, where the conduction system pacing is a class 2A. So we can do it if your coronary venous anatomy is not good. But what the guidelines do not say is much more applicable to us is the cost involved in the technology. CRT is much more expensive. We can actually manage the same result or if not better with a regular pacemaker. And in India especially, we have warranty lifelong for a dual chamber pacemaker, whereas CRT won't offer that. So these are not in the guidelines, but for us, I think it remains a wonderful option. Then you look at the 2B recommendation. In patients with EF less than 35%, LBB with QRS duration more than 150, class 2 to class 4, it's currently as per guideline is 2B. Then, but it's not all roses with left bundle. There is a limitation. Septal scar. Shanmugam has shown the different septals. LVH, if thickness is much more than say 14 or 15, then the capture may be difficult. Somebody already who has a VSD patch. Local lead dislodgement, septal perforation, septal artery injuries. Feasibility of lead extraction data is coming up, but we need more data. Conduction tissue capture may be difficult to demonstrate in some cases. And we need a 12-lead ECG or at least 3-4 leads. We need to ensure that during implantation, we are getting left bundle capture. And safety and efficacy, we are having growing evidence. And lead fracture, of course, we have already reports within our Kerala groups itself. But we don't want to see whether it is more than what is seen with the conventional leads. Conventional leads also not free of all these issues. Then, but as in the previous discussions, we have other nuances. It's not just like Hero Honda, fill it, shut it, forget it thing. There are much more to ECG during the left bundle pacing thing. Conventional CRT, we know it's pacing from an epicardial. I have 2 minutes more. From the LVCS, it's an epicardial, endocardial, but it was, even though it looks complex, the ECG interpretation was much easy. You look for an initial positivity in V1 with a superior axis in the 1 and AVL negative. But the left bundle, as Pogadendra sir was in the first presentation showing, a lot of intricacies in interpreting. I have given a simplified version. Selective, you have an incomplete RBB. You are looking essentially for the narrower QRS. And non-selective, you have a QRM. But again, this depends on your unipolar versus bipolar pacing. Then you can have the anode also add to it, giving an anodal, which can look like a near normal ECG. In addition to it, whatever the LV threshold we get during our technique, we got selective capture at 1. Ultimately, we will not keep at 1 volt for the patient. So what is more physiological, what we are going to keep is 2.5, between 2.5 or 3 when we discharge the patient. What is the QRS duration at that voltage? That is important. This is not done for CHB. This is done for heart failure. So we need the optimal QRS duration narrowing at 2.5 or 3 volt. Then the settings we need to remember, different captures we need to remember. AV delay and intrinsic conduction again can, like here, many of the time we are going to keep the LV, means not the LV lead, the conduction system pacing lead ahead of the LV lead. If there is an LV lead also, like it's especially for LOT hot CRT, that's a different topic. I'm not going to it. Many of the time we are going to keep the conduction system pacing lead as the first one. So all these we should be familiar with before embarking on conduction system pacing for all heart failures. In short, in patients with heart failure, non-inferiority of left bundle area pacing to conventional CRT in clinical and echocardiographic outcomes are observed. Accumulating evidence for long-term safety and efficacy is promising, but still under further safety thing is done, post-operative no escape patients may be still treated better with CRT because you have one more pacing lead to support. Thank you. I hope I stopped on time.
Thank you, Abhilash, for the excellent talk. I have one question regarding the subgroup you have briefly mentioned, the patients with failed biventricular pacing. That subgroup, what was the data actually? How was their performance after giving an option of conduction system pacing? And especially, what should be our threshold in offering this option when patients, two group, the failed IV pacing, one group which failed from the beginning itself, and the other group who has actually improved, but then due to lead failure, then again they failed. So what should be, anyway, they have got an expensive thing inside which is not doing a work. So what should be our threshold of offering a conduction?
Most of the non-responders are when it is an ischemic LV dysfunction or when they are not typical LBUB type. So this depends on the case selection itself. If it is non-responder from the very beginning, I think we can keep a low threshold for condition system basing. But conditions, again, it's limited by the scarring in the septum. That is a limitation. But if it is totally initially responded and then failed, means we need to find out why they failed. Why they initially they respond. There could be a reason. It could be the higher threshold in the LV lead, or the settings may not be correct. So we need to adjust it. If it's a totally non-responder and patient is deteriorating, definitely we can try this as a bailout. Or we have the new systems like YCRT system, where we are adding an endocardial LV lead to the LV.
The patients who are actually very long back because before the conduction system basing idea came, those patients, so again, non-responders, for them also.
I think non-responder and the clinical need for the new device, that decides. I think we can definitely try, provided we have the venous access.
Yeah.
It's doing it from the right side will be difficult, but still on the left side, if the veins are intact, already 3 leads are there. Whenever the practical issues for the second procedure is the venous patency.
Vilash, let me ask a non-EP question. Have you seen any left anterior descending artery injury?
I have seen a case report by Shanmugam.
Okay.
He published it. He has a septal injury in one of the cases. We haven't come across. Maybe we don't place that anterior, because most of the time the natural curve of the sheath takes us to the posterior portion, which is away from LAD septals. If you try more anterior, like an anterior fascicle capture, we may get into the septum. Or what is your opinion, Shan? Yes, that is reported. That's reported.
So it actually, when you go much closer to the his bundle, the septal branch of the LAD will come when you go higher up. So we tend to avoid. That was it happened in 2019. That was in the early stage when we were trying to capture as close as possible to the his bundle. Then we learned that we should go away from that area. But still, that exact etiology of that, the patient had a ST elevation in chest leads at the time of procedure. It resolved immediately. So our speculation was either because of an air embolism, because of through and through. It was a perforation during implantation. Then we removed it and redeployed it. At the time, there might be some air might have gone in, or maybe some septal artery injury producing intense vasospasm, because ST elevations were over the chest lead. So the ST segment settled within 5 minutes. I could do the angio after 30 minutes after closing the pocket. The angio was absolutely normal. But air embolism is quite common. I had 2 more cases of inferior lead ST elevations because of a tough procedure, had to work for a long time. That is because of through and through injury. But otherwise, injuring the left anterior descending artery is very, very rare. But septal hematomas are quite common. You might be injuring some small arteries and it may develop a giant hematomas. A lot of giant hematomas compromising the RV cavities are recorded. So it's better avoid multiple attempts and make sure that we do at least one post-operative echo just before the discharge to see what the septum is looking like.
One good thing about left bundle pacing is we are not limited by a small area. We can capture if it is anterior fascicle, posterior fascicle. Many of the time it goes to the posterior fascicle. But as long as our QRS remains narrow, I think we should be okay with it. Thank you.
Thank you, everybody.
We thank all the speakers and the moderators for that enlightening session on physiological pacing. Now we'll be moving on to the symposium on atrial fibrillation. We have 2 sessions. First on updates in AF, and second, the case in the box session. For the first session on AF updates, we invite Dr. Bahuleyan, Dr. Narayanan Nambudri, Dr. Ramdas Nayak, and Dr. Sajeev onto the dais.
Good morning. I think we are online, and the first talk is by Venkata Krishna, pulse field ablation. We all know that AF is a subject wherein a lot of patients come in, as we are seeing a lot of elderly patients. When should we go up for the AF ablation? We know that the success rate of conventional AF ablation with radiofrequency is very low, followed by cryoablation has come, even though the success rate is little higher than that. There is a lot of, in terms of financial constraint in India, we don't do it. Let us see what pulse field helps us in doing it. And the success rate of pulse field has been very high, to tune of more than 90%. Let us hear from the pioneer what he says about this. Over to you, sir.
Good morning, ladies and gentlemen. I'm Dr. Venkat Tolakanahalli from University of Minnesota. Thank you, Dr. Nambudiri and Kerala Heart Rhythm Society for inviting me to speak on pulse field ablation basics to clinical application. I don't have any relevant disclosures. So in the next few minutes, we will discuss on the topic of pulse electric field and what its role on arrhythmias and what is the evidence in atrial fibrillation, ablation, and perhaps the ventricular tachycardia. So what is pulse field ablation? Let's look at this video. This video depicts the high voltage delivery on the cardiac myocytes using these pulse electric fields. When the high voltage is delivered, the effect that you see is on the cell membrane. The bilipid layer causes the electroporation and the cellular organelles are affected. In the initial phase, there is a reversible component as the voltage and the energy delivery continues on, or perhaps the higher voltage, it eventually leads to apoptosis and hence the cell death. This is what happens, which actually enables us to look into this particular concept of energy for in applications with cardiac arrhythmias. So let's look at the pulse electric field waveforms. What kind of waveforms will be helpful and how it can be used? As you can see, there are 5 panels here, and it is depicted in the voltage per centimeter, and the x-axis in the form of the pulse width. And it could be in the monophasic waveform with a lower strength, monophasic in the adjustable strength, then the biphasic waveform, and a shorter pulse duration and an exponential decay you can see in this particular category. Each have their own benefits and strengths, and mainly the bipolar has got a reduced risk of skeletal muscle twitching. So the pulse electric fields controllable parameters, because of the fact that there are many controllable parameters in this situation, is one thing is the pulses in the form of micro, and currently the another set is the nanoseconds are also being used. Then the high voltage from 500 to 3000 volts per centimeter can be utilized in delivering the energy to an acceptable level in the cardiac myocytes. And there was a question about using the asynchronous versus synchronous with QRS. And there was some theory that the synchronous is helpful to reduce the risk of proarrhythmia, but that has been quite a bit debated, and currently it can be used in both ways in different situations based on the quality of the pulse electric fields. Pulses up to 90 can be delivered. One of the aspects of this form of energy is the how much is the cell arc, the shape actually matters. In this particular ellipsoid cell with a very slender area where the electrical field actually is delivered compared to the ellipsoid with bigger area being delivered, there is a significant amount of energy delivery seen with pore formation in this particular type of cell, as opposed to there is a C compared to the A. So what pulse electric field parameters that impact observed effect on tissue you can think about is apart from the pulse frequency to polarity to number of pulses to pulse duration and the orientation of the field vector, as well as the pulse strength and perhaps the pulse shape, may impact the pulse field ablation. So there are many controllable factors when you're designing this particular type of energy form which can affect the cellular architecture and damage. As we move from left to the right, the reversible electroporation to irreversible to thermal effect you can see. So if you are in somewhere in this particular area, you can have an effective form of ablation which is long lasting. This particular slide depicts different forms of energy and compared to the pulse electric fields. As you can see, one of the aspects you've seen is the concept of collateral damage. It's very minimal. As we can see in subsequent slides, the damage is actually very minimal to none, and the tissue specificity and reversibility potential is also very good. So it can be potentially used in this sense of actually using how much energy you want to deliver to reduce the risk, or if you want to reverse the pulse electric fields. So the pulse field ablation in this particular slide depicts the effects, histological effects in the canine tissue, and here it is the swine ventricle. This study was earlier done, which shows this is the control cell of the pulmonary vein, and you can see the cellular architecture of the PFA is preserved very well, hence there is no stenosis. And you can also see a very clear demarcation between the living cells and the apoptotic pulse PFA cell. That is one of the interesting aspects. The earlier gross pathological description was difficult because they couldn't see much in this particular study, but has been recently shown by Koruth that you could visualize in some form in the gross pathology. In this particular case, you can actually clearly see there is myocardial disarray seen during the time of ablation, ablated region as opposed to the normal, and there is a clear penumbra of hyper staining with enhanced activity in the Cox staining noticed around this area of lesion. What it means is unclear. It could be electrically, it may make some form of a stunning activity in this region as well. This indirectly needs to be studied in a long term with respect to knowing what it really means. So the PFA has got somewhat interesting characteristic with respect to cardiac myocytes, because the cardiomyocytes have the lowest sensitivity, and hence it can be very much titrated based on how much energy you can deliver, and you can be delivered extremely fastly. And then because of the risk of coagulative necrosis being absent, the pulmonary vein stenosis is almost not a possibility. So the first study which was done through a company by name Iowa Approach, and I was involved earlier in the animal study for this epicardial approach, where this catheter goes around the pulmonary veins and the posterior wall, and subsequently the endocardial catheter with the flower-based technique was also used in the earlier first-in-human study. So as you can see here, depicting the maps of pulmonary pre and post ablation, endocardial and epicardial, clearly you can see a nice pulmonary vein isolation, and here pulmonary vein isolation with epicardial. This particular characteristic seen in the endoepicardial gave a very good idea that I think this is a very promising technology in the first in human study, and hence subsequent studies were performed. And these are the results of 1 year pulmonary pulse field ablation outcomes in the IMPULSE, which is the Iowa Approach study, and the PEFCAT and PEFCAT2, which is the FARAPULSE study. And this study was carried on to look at the results of this particular study. I'll tell you in the next slide. As you can see, this particular catheter has got the basket shape here and the flower shape here, and it is depicted in the gross form. When the catheter is against the tissue, you can clearly see the cardiac myocytes are clearly necrosed, but it spares the nerve cell and the vascular smooth muscle cell and the esophagus. We'll talk about a little bit on the vascular muscle later. So the effects of this particular ablation, what did it do? As far as the safety is concerned, absolutely no collateral damage in this particular study. So no pulmonary vein stenosis, no atrioesophageal fistula or esophageal damage or the phrenic nerve injury. Patient, there was a 0.9% TIA effect, perhaps the learning process with respect to the anticoagulation protocol. And there is 2 cases of pericardial effusion, which was also one more thing is about knowing the catheter, and because of the sheath vascular injury in the beginning. So overall, there was optimization protocol used in this particular study over a period of time among these 3 studies, where the pulse field ablation were optimized to different forms, and hence subsequently the outcome starts getting better and better, and overall success rates were in the range of 80% for the paroxysmal atrial fibrillation 1 year outcomes. So this is not much different from what we have observed in the radio frequency, but with a lot of benefits due to the pulse field in the earlier stages. Obviously, this is a brand new technology. So the focal ablation of CTI was also performed in some group of patients successfully, very short duration, this was another promising tool as well. The other system, which is the Afera system, is used, which is a combination of RF and pulse frequency type of ablation type of energy source, where posteriorly was a pulse field ablation was done, anteriorly RF. I'll compare it to both sides, and the outcomes are fairly similar. And in this pulse 1, pulse 2, and pulse 3 is talking about the optimization protocol over a period of time, and the outcomes were fairly similar to what we have seen before, almost close to 80% success rate with respect to the outcomes. So what does different forms of energy affects the autonomic nervous system is the next question. So if you look at the pulse PFA catheter, the 3 months outcomes, there is no heart rate change as opposed to other forms of energy. There was 10 beats increase in the heart rate. So acutely, there was evidence of some vagal response seen with the PFA, and the ganglion plexi were tested before and after using high frequency stimulation. But the overall, by the end of the procedure, there was a significant recovery at the end of the procedure, indicating nerve cells are less affected. So there are multiple systems that are being developed. Biosense Webster has different catheter system, and the Abbott system, which has got the balloon one, and now the catheters have been with the combination of RF and PFA, and the Medtronic Pulse Select and the Afera. All these are very promising tools with respect to what it can be utilized in this group of patients. The other system, which is a very interesting concept, which is being developed, which is being tested already in the humans, is the globe. This catheter is delivered, it forms a globe in the LA, and it can be used as a mapping tool. The electrodes are very specific where you can ablate and stimulate, and it can be quite useful in this aspect. So what does it do with respect to hemolysis aspect, which has been a topic of debate? And the recent study shows that if the catheter is in contact with the tissue, there is a less chance of hemolysis in the in vitro experiments as opposed to the floating area. So the coronary vasospasm is known to be an issue when the pulse field is applied very close to the CTI region, for instance, in this case. This causes coronary vasospasm. And this can be prophylactically negated by using intravenous 1 to 2 milligrams of nitroglycerin, or intracoronary if there is a spasm. So that is a reversible component. It doesn't really cause a damage as of now. So in conclusions, ladies and gentlemen, pulse field ablation is a promising ablation source of energy, high predilection for being cardioselective with pulse PFA characteristics, less likely to cause collateral damage and a very short procedure time. The AF outcomes currently is similar to RFA, but we have to wait and see for a long term. And there is a potential for VT ablation, as one case was presented using the field medical technology, using a field bending, and is capable of causing a very significant impact on the VT as well. Thank you very much for your attention.
Thank you, Dr. Venkat. It was a great talk, highlighted all the important aspects. My query is that though the initial results were quite promising, I mean more than 95% success but still the 6 months, 1 year follow-up studies are more or less equivalent to that of RF and cryo. In fact, a study showed slightly inferior value as well. So is there a higher chance of reconnection, or it's still in the learning curve? What is the reason for that?
Thank you very much for a great question. In fact, one of the things which is being under study, I think as I kind of briefly alluded to the Hiroshi Nakagawa's histological work, one of the things we are slowly understanding is because the pulse field, when it is delivered, one of the problems you see is you lose the electrograms immediately, and acutely it looks like you cannot really know whether the ablation is done as a reversible component. Could there be a reversible component still present? This is obviously a debate. There is no parameters at this point of time to know the tissue feedback. So I think it's a question of time. I think all the companies currently are working, as I understand, regarding trying to find out the lesion quality. So I think that's probably the key to know on a long-term basis what it means really. So I think it's very promising because it's so early. It took about 20 years for us to understand RF. What exactly it's, how we can, we are at this stage, it took a long time to get here. Similarly, I'm thinking the PFA will take a little bit of time for it to optimize to a level where we can actually know exactly what the lesion characteristics are.
Thank you, Venkatakrishna, for the nice talking. My questions are not possibly to the technical aspects of the newer method of ablation. What I'm trying to say is that in Kerala, the number of patients undergoing ablations are very few compared to what's happening in Europe and US. In an atrial fibrillation registry which we conducted about 8 years ago, we found that among the treatment modalities, only out of 3,421 patients, only 16 patients underwent ablation. 14 were non-valvular AF and 2 were valvular AF. That was the situation in 2016 to 17. Now, of course, 8 years have passed, things might have changed. Year and a half ago, we have Nampudiri has done a evening meeting on ablation, and one guy from Italy, he came and talked that it's very common patients being referred for straight away for ablation therapy, especially paroxysmal AF, patients with heart failure not responding. As we all know that heart failure and atrial fibrillation combination is a very difficult to treat situation. And if you hit patient gets a recurrent AF and destabilization and recurrent hospitalization in consequence to onset of paroxysmal AF, perhaps those patients would preferably be referred to ablation. And what in my experience I found that I have started referring for the same thing a few years ago, and find that the patient acceptability and including the operator offering is rather vague. Patient acceptability is the physicians or treating physicians' responsibility to encourage them to accept that. But even the doctor who is going to treat is not giving a very confidential advice that it will be safely done. And that is the context where I assess the newer modality of PF ablation. I understand that it is safer, faster, and probably it is very efficient also. You have showed some coronary spasm happening, but I'm sure it may be lesser than the other modalities, the established modalities of ablation. So is it going to be a practice-changing pattern in terms of ablation from the patient preference side as well as the physician preference side? That's my question on that aspect. What's happening in your place once this has been introduced in these areas? I would like to get your message.
No, very good debate. This is in fact a debate, I would say. As you know, after the East AFNet 4 trial came in, and also the multiple trials on the heart failure, the indications, the guidelines has shifted to class 1 in the heart failure and class 2A in the other groups. So that has changed a lot of practice patterns with respect to referral. It's a question of, I think, patient education. I think patient education, the more the atrial fibrillation ablation we do, I think more we get better as well. It's like anything else, like left bundle pacing, for instance, what we saw previously. Over a period of time, it becomes a nature of getting the technique very well done. Yes, the biggest. This is also there will be a learning curve with respect to even the PFA. And I'm not surprised that the question, when we iron out all the other problems that we are currently facing, the biggest cost issues will be an issue because the catheters look like at this moment quite expensive, and over a period of time that will also reduce the cost, mainly because in Europe, a lot of places they're not even using the mapping system. They are going by fluoroscopy and intracardiac echo guidance. Although eyes can be quite expensive again, and some places are even doing just by the fluoroscopy technique, similar to what you do with cryo. But of course, you don't need to use contrast and other things. So in this way, I think it is going to change quite a bit. Especially, you don't need to monitor esophagus, phrenic nerve, and all those things. So at some point in time, I think there is a big shift, at least in the atrial fibrillation side standpoint of view, that PFA will be the energy source. But I think the RF is not going to completely go away, because some of these flutters, we see complex flutters particularly, we have a lot more persistent in our group as opposed to paroxysmal. In that situations, these complex flutters may still probably need the RF in that situation until we iron out and see what's the best way to reach this kind of arrhythmias with respect to the technology-wise. All these questions, what you mentioned, is practical and important.
Thank you very much.
I want to ask you one question. Would this replace the earlier forms of energy? Because I think you showed one case where it was a combination of posterior PFA and anterior RFA. So is this going to, will the other forms become obsolete?
Yeah, but this was even debated last Heart Rhythm Society. I think what is the reason why we really need RF in this situation for anterior side? I think the trial was done with an intention that a lot of physicians are still more used to the catheter-based point-by-point technique, RF ablation, quite a few people, other than the cryo users. So this may be an easy transition for them, and I'm not surprised that it is less likely that we are going to be using this technique when it comes to choosing between RF and PFA. We'll be using more of a PFA because it feels more safe and the energy delivery is much more determined, and it looks like it penetrates the scar. If there is any evidence of a scar, maybe you can get to the epicardial surface much more better without causing the collateral damage. I think it's a question of time. And when it is closer to the coronary vasculature, possibly RF can be delivered a lot more safer as opposed to delivering with PFA to avoid the coronary vasospasm. Incidence is small, but it is not zero. That I think the spasm can happen if it's closer to the proximity of the coronary vasculature.
Thank you, Dr. Venkat, joining us despite your busy schedule. So.
No problem at all. It's my pleasure.
Yeah. Let us move on to the next talk of the session. That's on device-detected atrial fibrillation, how to approach, by Dr. Praveen Srikumar.
Good morning. I'll go straight to a topic. Introduction. AF has been traditionally defined as a ECG documented arrhythmia at one point of time. In its simplest definition, it is independent of duration of arrhythmia. We have not been talking of AF burden so far. So it's a 1 point diagnosed by ECG. And there are a lot of guidelines which has established role of anticoagulation, stroke prevention, extra in already ECG documented AF. But with device documented asymptomatic AF, the studies are less. Whom to anticoagulate the asymptomatic group is not well established as of now by documents. So the management of subclinical AF is still a doubt. Whom to anticoagulate, whom to refer for ablation is still a doubt. So by document, what do we have as of now? That's what I'm going to cover up. In patients with stroke, about 20 to 40% is a group called unexplained stroke, unexplained cause. It's called as stroke with unexplained cause. So among these unexplained strokes, 10 to 30% are AF which has escaped detection. So that's a general incidence. And among device detected atrial arrhythmias, that's a present definition, there are various subgroups. AHRE, which is high rate episode. So any atrial lead which is sensing any higher atrial lead episode more than rate of 175 is called as a AHRE as per present definition for study purposes. And subclinical AF is asymptomatic episodes of true atrial fibrillation detected on a device EGM or ECG or ambulatory monitoring devices. And subclinical atrial arrhythmia is asymptomatic episodes of fibrillation, flutter or tachycardia detected on devices. So it can be either incidental finding on a implanted or wearable device. It can be during monitoring for other causes, or it can be during a stroke evaluation. So the problems are that there is a high false positivity rate for device detected arrhythmias. Most of the, especially when there is no atrial lead, true atrial lead. Among the most common is the pacemaker detected where there is a atrial lead. But in a single chamber pacemaker, sometimes there may be false detection of atrial arrhythmias. So another problem is what is the impact of the symptom status, burden, etc. There are less studies in this aspect, and there is an uncertain role for anticoagulation in this asymptomatic group. So AHRE may be AT, flutter or AF detected on devices, and it may look like this. There may be atrial sense and paced events on marker channels, or we can see the device monitor for atrial or ventricular rate episodes. And as I told, the atrial lead detects AHR, but if there is in devices which does not have a lead, the detection is by variations in RR integral and narrowness of QRS. So that's how AHREs are detected. And sometimes it is better to manually check a atrial rate episode by manually monitoring the device, because sometimes you can get T-wave oversensing or atrial noises which may be detected as AHREs. That's a problem with this. And even in patients in the ESSER trial, most of the patients were patients with pacemaker. That's the most common sort of patients with device detected AF. So 80%, about 82% of were actually true AF, and to almost 17, that's almost 1/5 were false positive, even with the atrial lead. So with other devices, it should be more higher. So the effectiveness and anticoagulant has been shown in patients with already detected AF, documented AF, but in device detected AF, there is no concrete evidence as of now. Now there are only ongoing trials, randomized trials going on, which will probably give results in the future. So this is the evidence. There's an evidence gap for practicing physician, and generally, if you see the incidence of AF, the subclinical AF in stroke patients, already patients who have had stroke, when evaluated, roughly the incidence is around 11.5%, and in patients in a high-risk population without prior AF, patients who have already had a stroke and high-risk population without prior AF, the yield of SCAF is very significant, and this also depends on the time of which monitor is put. It is definitely more than a single Holter, 24-hour Holter. And if you take the incidence of SCAF, it is associated with the SCAF is associated with 2.4 times risk of stroke, and the absolute annual risk of stroke for about 1.89 per 100% years. And this also differs among studies, because there is different definition in most of the studies for definition of what is a stroke. What is the duration of AF which is defined. For example, in most trial, and assert the duration of AHRE was 5 and 6 minutes. That was associated with a higher risk of stroke, and increased risk was observed in more than 5.5 hours of AF in trend study. But in assert trial, again, other definitions gave other incidence of stroke and other significance, like later sub-abdominal analysis showed that finally more than 24 hours is a good cutoff point. So the cutoff point varied among studies over time. And definitely what was noted was short AF episodes, less than 20 seconds, was not associated with clinical events. This is for significance of anticoagulation. This was, the blue line is the 24-hour AHREs. That is definitely the Kaplan-Meier survival plot differs. So probably we can take 24 hours as a good cutoff for deciding whether to anticoagulate or not. And there are other studies which shows the same. And some in initial monitoring age, and mainly in assert and most trial, AHRE more than 5 to 6 minutes, the risk of stroke was around 2.5 to 2.7 times than the usual population. And if we take predictors of SCAF, mostly patients with sinus node dysfunction with higher ventricular pacing requirement was associated with more stroke. That is already known. And in patients with AV block, only hypertension was a independent predictor. In TRENDS trial, other studies showed different clinical parameters also, not just the rate of AF or number of AF episodes. Other clinical parameters also were associated with a higher risk of AF. So it's not just the incidence of AF. Other parameters like high NT-proBNP, sleep apnea, increased BMI, CHAD-VATS2 score, which includes many clinical parameters. But in some other meta-analysis, when you take a meta-analysis, there is conflicting evidence. For example, hypertension, diabetes, thrombotic events, CAD, and CHAD score did not associate with incidence of SCAF or SCAF predicted stroke. So what should we do when we have conflicting event? What should we do when we detect a pacemaker related AF? When is it significant? Do they increase stroke risk? If so, by how much? Should we initiate an oral anticoagulation for stroke prevention? Is it worth the bleeding risk of long-term anticoagulation? Should we manage the AF more actively, and will that prevent the stroke? These are the questions that clinician has. And the problem with the studies documents so far is that there is lack of standard definition to compare. And is it AF per se causative also? It's a doubt. Is it AF per se which causes stroke, or is it just a part of overall risk factor for a stroke? So in the ASSERT study, the annual thrombotic event rate was 1.7%. When the HRE, in the initial inclusion for the first 3 months, they were included. So in that, there is a definite increase in incidence of stroke of 1.7% versus 0.7%. So there are comparable things in other studies also. But there is another problem that stroke occur equally in periods with and without AHRE. So that was also another problem. So even the AF may not be detected when the patient is in stroke. So, and it was also seen that when the AF was running at the time of stroke, that did not correlate with the timing, temporal timing. And the another factor was the traditional risk factors, where the CHAD-VATS score of more than 2 definitely increase the risk of stroke, even if it is less than 5 to 6 minutes of AF or AHRE. But CHAD-VATS score of 1 and added increase in risk duration was more if the AF was more than 24 hours and CHAD-VATS score of 1, that also increased the risk of stroke to about 5%. So whether the AF is a part of a general risk factor for stroke or AF is directly causing stroke, that we have to. If this is a second one, then we need to actively treat AF, actively need to see the AF burden, quantitate the AF burden actively. But if it's just a risk factor, then we just need to treat the risk factors rather than treating it as a separate entity. So whether the cardiac monitoring, definitely cardiac monitoring incidence of the SCAF is very high, 16.1% when compared to just 24-hour repeat Holter monitoring of 3.2%. Since even as the duration of monitoring goes on increasing, the incidence of AF naturally goes on increasing up to 30% at 36 months. So the predictors of SCAF was not just the atrial ectopics more than 500%, there were also clinical variables and also PR interval. So what that means is it's not just the AF as such, it's also the risk factors which is important. So generally progression also changes over time. So I'll finish fast. And there is definitely heart failure is associated with AF, 50% in severe heart failure. And whether to give anticoagulation SCAF. In the absence of such a definitive evidence, clinical evidence, it is reasonable for clinician to consider 2 things. One, if SCAF duration is more than 24 hours and combined with the presently available CHAD score. There are some problems with this. Of course, two randomized trials are addressing this. One is NOVA trial and RTCR trial. Results are not yet out. So probably as of now, what we can take is that CADTs it's common in patients with TA or stroke. Absolute risk of stroke is 13% and 2.5% risk per year for stroke and 4% per year if CHAD score is more than 2. So we need to take CHAD score also into account. Although detection of SCAF provides an opportunity to detect risk of embolic stroke, many things that we have to take care is first we have to verify whether it's a stroke or whether a false positive HRE episode on the device. Second, whether the AF burden quantification, that is also important. Third is clinical. Also, we need to assess the risk factors like CHAD-VATS score, etc. Only CHAD-VATS score is available now. Whether that is applicable to asymptomatic device detected AF is not very sure. So the combination is that we can take that not only HRA episode, also the clinical risk factors to be taken. We can take that, we can defer anticoagulation for patients with no stroke risk factors or those who don't have only very brief AHREs. These patients we need not anticoagulate, but we can consider anticoagulation for AF more than 24 hours and also with other cardiovascular risk factors. That is what we can take now.
Thank you very much. The one thing is that this problem was in front of us for the last few years. The device detected atrial fibrillation, what to do. In my practice, I have not yet started any anticoagulant therapy for that. This is precisely because there is no definite guideline to support it. We have only observational studies. Still, recently two randomized controlled trials have been published. Yes, that is Artesia and the NOVA AFSET 6 studies. Both the studies have given again different conclusions. One is with apixaban, other is with edoxaban. The apixaban study actually has been stopped prematurely because of the increased bleeding rather than reduction in stroke in these sort of patients. And the NOAF study, of course, it has reduced the reduction in the stroke, but it is much less than what we get in the clinical AF in the previous studies of apixaban. Whereas the bleeding, intracranial bleeding, major bleeding was higher. We know that this device detected group, the stroke risk is much less than clinical atrial fibrillation. So that we are targeting with these drugs. And we get major bleeding in both apixaban and edoxaban is higher. So that is again leaving us with a confusion as to whether to treat them or not. I think we have to go in more guidelines in this area to get before we definitely say about chasing these things and treating with anticoagulants.
If CHRS score is very high and if it is a device detected AF, how to proceed?
That's right. If CHRS score is, they say if more than one study showed CHRS score more than 4 and device detected AF more than 24 hours, if we so then there will be probably a definite benefit.
On wearable devices, if it is detected, how to follow up any guidelines? Because we have so many wearable devices like watches and all.
No, there are no guidelines on follow-up. Most of the studies that have followed up continuously for about, because it's a device, so they have followed up for 6 months.
I think one point, this one sub-analysis of a edoxaban trial has recently been and the observation was that there is no interaction between this impact of oral anticoagulant with CHRS scoring. They have put in 4 above and 4 below. There is no impact. That is what is shown in that. So I think we still are confused at that stage.
In fact, the Artesia trial is out. NEGM published it a couple of months back. In fact, that addressed the same population what Sir asked. It is the average CHRS score was 3.9 and apixaban has had a major bleeding risk of 1.7% versus aspirin of 0.94. So in fact, major bleeding. So probably we have to be very cautious when you consider anticoagulation, even at high CHRS score. Maybe we need more better indicators like LA smoke, LA volume index, underlying condition, the degree of LA fibrosis. So those things, indirect markers, would probably help more.
None of the studies have addressed the fibrosis parameters.
Yeah, we see some of these cases with a significant fibrosis on EP study, and some are very healthy despite high CHRS score.
Even strain parameters are not included in these studies. Probably it will be in the future. Atrial strain parameters.
Yeah. So I think in the interest of time, we need to conclude.
Nambudri,
only we'll move for.
Dr. Nambudri, before the next speaker comes, a quick question. Sir was discussing.
I'm the speaker next.
So you can hold on for a second. See, he was asking whether the Apple Watch, etc., will tell you about the duration of AF. It will tell you had AF, but the burden cannot be assessed, right?
That's what the reliability of a watch in comparison with the Holter. I would always go for the Holter rather than the watch.
Unless the
We thank the speakers and chairpersons for the enriching session on AF update. For the next session, that is case in the box session on atrial fibrillation, we invite Dr. Bijulal S., Dr. Shifas Babu M., Dr. Thomas Titus, and Dr. Venugopal K. to chair the session.
We have two case in the box sessions.
So we are going to the first case in box session. It is on cryoablation of AF. Bhavalen sir was telling about a little bit of some inertia from the operator regarding giving the option of say AF ablation, but probably it is little less now with the advent of cryo. I find more cases being done. Operators are being more aggressive about offering this therapy in AF. Let us hear from Dr. Narayana Nambudiri.
Thank you, Dr. Bijilal and other respected chairpersons and my teachers. I'll directly go to the talk. This is actually an index case who presented us a couple of years back. A 53-year-old male with episodes of palpitation and giddiness for preceding 2 years. In fact, his problem was episodes of pre-syncope following these episodes of palpitations suggesting a post-termination pause. He didn't have many risk factors except that he used to consume occasionally alcohol. ECG showed atrial fibrillation with the X-ray did not show any cardiac enlargement. This was depictive of the post-termination pause. He was on Concor bisoprolol 2.5 milligram because his tachycardia episodes were quite symptomatic. And despite that, he continued to have both palpitation and the termination pauses. As per the indications by the ESA criteria, this fits into the class 2 indication, that is AFib catheter ablation for PVI should be considered as a strategy to avoid pacemaker implantation in patients with AFib-related bradycardia or symptomatic pre-automaticity pause after AFib conversion. So we have a couple of energy forms available. However, cryo has got definite advantage in form of less collateral injury, more precise lesions, better demarcated lesions, and probably a decreased risk of thrombus formation. Here what we do is an single shot approach. A balloon is inflated to occlude all the pulmonary vein successively, and with a catheter, a multipolar catheter into the pulmonary vein, we map electrical isolation during the procedure. And this is done in all the pulmonary veins sequentially. And the form of energy used for cooling is nitrous oxide. The liquid nitrogen is produced through this console. There are multiple connections with the limited time. I'm not going through them. Basically, you have a flux card sheet through which we introduce this arctic front balloon. Then through it, we introduce this Achieve advanced catheter. You can see at the right-hand corner how these are assembled. And then we, one after another, we sequentially isolate all the 4 pulmonary veins. So the selection of cases as per the guidelines in this case, the options were discussed, detailed echocardiography is performed, a dedicated 256 slice cardiac CT is performed, TE to rule out pulmonary vein, to rule out intracardiac thrombi, nilperorally, deep sedation with a laryngeal mask airway, not with intubation, and with no diaphragmatic paralytic agents. As we could hear, diaphragmatic paralysis is a major problem that can happen, one of the complications that can happen with the cryo. The assembly that the hardware includes a 28 millimeter 4th generation cryo balloon. This is a 10.5 French balloon catheter introduced through a 12 French steerable sheath, spiral mapping catheter, which is called Achieve. Then 3D electroanatomical mapping is done in all cases with us. Image integration, esophageal temperature monitoring is a must, diaphragmatic function monitoring, eyes guidance, ACT monitoring, arterial pressure, and low pressure irrigation of the sheaths. Here's the CT. We take a detailed CT with 256 slice, and the IC is used. 3D, we have merge, then also esophageal temperature monitoring, all are shown. And we do a detailed echo, assess all LA volume, strain imaging, and the pulmonary vein parameters are clearly taken. You can see the pulmonary vein indices, eccentricity index, volume index, all in detail analyzed for all the cases. Then the segmentation is done in the lab. This is to take the clear LA anatomy. Then 4 lines, right in IJV, right femoral vein, LF vein to 2, radial line, esophageal temperature monitoring, continuous low pressure irrigation, heparin 1000 units in the beginning, then 7,500 immediately after septum puncture. Total we give around 10 to 15,000. ACT should be maintained at 350 and should be monitored every 15 to 20 minutes. We take an anterior inferior interradial septum puncture, often with the fluoroscopic guidance, but we also take ICE guidance to make it more accurate like this. The ICE reflects here, it's LA appendage, so it is an anterior puncture. The indentation of the septum you can see. You can, based on the ICE, you can take whichever direction as needed. All the four pulmonary veins are mapped, LA geometry is created. The purple color indicates the left atrium is quite healthy in this case, and you have pulmonary vein potentials that is depicted here. And then each pulmonary vein is entered sequentially. Here's the LSPV is entered with achieve, then LSPV occlusion. Occlusion is with a contrast, pressure tracing, and the ice flow. Then pulmonary vein occlusion is shown with ice, or the one is occluded, another one is still leaking. So that is clearly noted in the ice. Ice makes it much simpler. You can see on the left-hand side, the temperature drop, that is minus 16, minus 24, minus 29, and the time is shown down, that is 14, 15 seconds. So if you reach a temperature of minus 30 by around 30 seconds, that shows you have a very good occlusion and it's delivered properly. And sequentially, you can give for a period of 240 seconds for the left side. You can see the left superior pulmonary vein electrically isolated, very clear and crisp, abrupt isolation of the pulmonary vein. Unlike radiofrequency, there is no ambiguity in the diminution of size, is now it's abrupt cessation of electrical activity there. Time to isolation 180 for the right side, 240 for the left. No isolation by 90, a reattempt is made, and persistent pulmonary vein isolation should be verified after 10 minutes of the procedure. You demonstrate exit and entrance block. Esophageal temperature is to be monitored. You can, beneath you can see that this is 35.6 here. Then in this case, it is coming down, it's 27.1. If it comes below 27, we stop and immediately double tap and stop it. So that is to make sure that esophagus, retroesophageal fistula is avoided. Left inferior pulmonary vein isolation, again see the electrical isolation clearly coming up and that is so abrupt. This is the isolation point. In certain cases, like this case, we had isolated the left inferior pulmonary vein, and you can see the pulmonary vein is isolated, but if it goes on into the pulmonary vein, so patient is in sinus rhythm, but you have atrial fibrillation going on. This is during isolation, and with sequentially with the continuation of the energy, you can see even the termination of the atrial fibrillation in the pulmonary vein at this point. So here, the termination of atrial fibrillation again, isolation, the patient is going into sinus rhythm. Again, positioning for the diaphragmatic pacing, this is very important. This quadripolar catheter is placed in the somewhere close to the SVC, and you give and make sure during isolation it is completely monitored. Also, you have complex motor action potential. This is a modification of the lead one. The positive deflection here you look at, and also you can, hepatic excursion can be seen with the eyes. Right inferior pulmonary vein isolation here. And when you isolate these things, it's very, very important to monitor the diaphragmatic contractions. The temperature, if it goes abruptly to minus 50 or 60, generally we stop. And also contraction comes down, we stop, and we keep a hand on this. And it's monitored every second the pacing spike comes. Very, very important. Cannulating the right superior, additional right middle, essentially the same. Then we create a voltage map to assess the lesions. That you can see clearly, I said these gray zones are electrically isolated. An electrical isolation of all pulmonary veins confirmed afterwards. An exit block is also demonstrated by pacing it. And finally, we put a figure of 8 and come out. Post-procedure care is as in any other RF ablation, a blanking period of 3 months. We continue on amiodarone for 3 months. In Chitra, we had done 53 cases since March 2022, 25 months, mean age 56 years, 3 redo cases, LA mean of 36, 16 cases had LA diameter more than 40, 3 had more than 50, largest is 63 millimeter,
All cases had 3D electroanatomical mapping. ICE was used in 60% of the cases, hybrid approach in 4 out of them, mean follow-up of 16 months, maximum follow-up of 25 months. Adjuvants like 3D mapping, prior MDCT, image fusion, esophageal monitoring in all. ICE in 60 cases. LA dwell time is 63 minutes. LA fluoroscopy time is 34 minutes. And pulmonary vein isolation in almost all. And so no major complications. Out of our patients, mean follow-up of 482 days. And clinical follow-up in all, we have patient this 45 out of 52, that is 85% surviving had no recurrence after a belonging period of 3 months. My last slide, this freeze comparative studies, and our patients is actually 18 months, it's 16 months, not 13 months. We have 85% remaining sinus rhythm, and in fact, this is much better. This is actually 12 months. Ours is 16 months. So concluding, cryoballoon AFib resulted in electrical isolation in nearly all, and at 85% of the subjects remained free of AFib, and no major complication, short LA dwell time, and good efficacy outcome at near 18 months of follow-up. Thank you all. And in fact, in this long journey, we had so many mentors helped us to almost 1/3 of the cases we had done with the assistance of mentors, at least in the initial phase, that included many pioneers in the field. Thank you all.
Sir, I have one question, sir. So as a non-electrophysiologist, what sort of patient I should refer or I should counsel for cryoablation?
We are very strict about the indications. We had actually canceled cases because the patient was not screened for obstructive sleep apnea syndrome. We go by the standard definition only. AHA guidelines, we follow that. We are not afraid of doing any case actually. We have done even 63 millimeter left atrium, because Bailey sir was telling we are not afraid of doing, but it has to follow the clinical indication. Like even chronic atrial fibrillation we had done, but it should follow the standard guidelines. Generally, paroxysmal atrial fibrillation, refractory to either flecainide or amiodarone, at least should have had one recurrence on flecainide, because flecainide is quite safe. Amiodarone, depending upon the patient's inputs as well. Otherwise, post-termination pauses, patients with a tachycardiomyopathy, it is class 1 class 2A for post-termination and class 1 for tachycardiomyopathy or heart failure. We're very aggressive on that aspect. But if you have an LA of 60 millimeter, patient is asymptomatic on rate reduction drugs, and everybody feels it is not clearly indicated, we generally are not, of course, it is risk versus benefit as in any other medical procedure.
This index patient which you discussed, did he undergo a pacemaker implantation?
No, he is totally asymptomatic. He's a businessman in North Kerala. He is totally asymptomatic. Is one of the first patients.
In this series of 60 cases, how many were first AF, or all were initially managed otherwise and taken?
None of them is first atrial fibrillation. Almost all of them had at least 3 months of interval and had screened for all associated risk factors. And also they had been on at least flecainide or amiodarone, unless it is a post-termination related pause or a cardiomyopathy cases.
You don't have risk of phrenic nerve problem on the left side at all?
No, it is not a complication on the left side.
And you do both the stimulation in the SVC-RA junction and keep looking for diaphragmatic pacing.
Yeah,
and also do the action potential monitoring?
We do all of them. But generally monitoring alone would be sufficient. But we monitor as a standard protocol, we take all these things. Keeping a handover is probably the best approach. And you can or fluoroing is equally good.
Fluoroing in spontaneous respiration or pacing? Pacing based.
And you put at unit 1 and 4, we take the quadripolar so that it captures the diaphragm properly. And we keep a hand and also monitor fluoroscopically intermittently. And CMAP also is, CMAP is very sensitive.
And this, how challenging is this fusion between CT and this NAVIX?
No, it's pretty simple. We have been doing it for 15, 20 years. So fusion we have been doing since 2009, and just Sabari does, it's very well. So not a problem at all.
All the previous versions also are compatible with this thing?
It's compatible. It's a very simple job.
You don't exert a steam.
No, but number three, I think post termination pause may not be an indication for a pacemaker. So, but in a patient with sick sinus tachybrady, how do you decide whether that patient needs a pacemaker or whether it is a pause related sinus node suppression needing a pacemaker?
Sir, if it is clearly post-related sinus node depression without significant intrinsic sinus nodal abnormality, AFib ablation is clearly an approach, class 2A indication. But if you have a 80-year-old with both sinus node depression and tachy and all, he needs more medication, either amiodarone, beta blockers, it is better to put a pacemaker and try, because young patients may still would like to have an attempt at ablation, and actually it works very well. That is probably the group where it works wonders.
And do you have triggers in SVC oblique vein of Marshall?
So those things will not be covered by cryo. In case if it persists, that is the reason for failure in at least one of the patients with the paroxysmal AFib. You may have to use a hybrid that we actually use. Our cases are not pure cryo, it's actually hybrid. Without any additional cost, we can put an RF catheter and ablate. That is advantage in India, because the reuse of the catheter, RF comes reasonably free of cost. Western countries, it is purely cryo, PFA or RF. Here it is almost all the cases in a dedicated lab, it is a hybrid procedure.
But SVC is accessible, no? Because a muscle sleeve can go into the SVC
Cryo
from the
people
RI.
have not done.
Sir, wonderful talk. Two questions actually. Over your experience, what has been the additive advantage of CT over an ICE when you have ICE and CT? What is the added advantage that CT gives? The second thing is on the CT, if you find an additional middle vein on the right side, so is there a size cutoff in which you would take in and freeze those veins, or based on your CT experience?
ICE, we are comfortable, but we are not in a position to, experience-wise, we are not in a position to replace it with the conventional fluoroscopy. Or CT gives a clear advantage of the clear delineation of the anatomy prior, like additional pulmonary veins, which we would have otherwise missed. Regarding right middle pulmonary vein, it happens almost 20%, 1/5 of the cases, a left common pulmonary vein and a right additional pulmonary vein comes. Here we go and isolate the right superior and right inferior first, and then we look at the right middle pulmonary vein. We know in the CT that is a right middle pulmonary vein. We get into many times balloon may give, I will not get into the proper shape and cause, and these veins are actually at high risk to cause a diaphragmatic polycy, because we generally ignore that. It is middle, somehow it causes. We had one of these cases in the right middle.
Because these middle are smaller, it usually gets prolapse out.
Prolapse. So, and then we give somewhere if it is not isolated already with achieve catheter. If it is not isolated, we apply it at the antro.
CT, can you say a size where you wouldn't?
We have not looked into that.
No, but if the cost is not a factor, as a general cardiologist, just wanted to know, if cost is not a factor, would you prefer a cryoablation rather than the conventional?
So cryo we would prefer, because the LA dwell time is quite low, and also the procedure for the operator as well as for the patient, it is less damaging, not much of collateral damage, especially regarding the major complications like pulmonary vein stenosis, because balloon prolapses, and also fistulas. And in fact, the cost is, initially we used to charge 5+ with some modification and industry and all. We would be able to reduce it further in future, or even now, we believe.
I think we'll go to the next case. Let me invite Dr. Arun Gobi to talk about LA appendage closure. Arun is a very dynamic electrophysiologist in the North Kerala, the place where I had my own sort of my life in cardiology in Calicut. So, welcome, Anil.
Respected chair, teachers and friends. So, moving on from the arrhythmic issue with AF, going on to this risk of stroke. Starting off the index case, this case was done many years back, but Jyoti wanted to present this because this topic he wanted to dwell on. This is a story of a 70-year-old doctor, diabetic hypertensive, post-PCA on aspirin, troubled by recurrent paroxysms of AFib for the last 15 years, tried with multiple antiarrhythmics, amiodarone and beta blocker, tried to the maximum tolerated dose, continued to be symptomatic, had recurrent episodes of neurovascular ischemia, unfortunately not tolerating both vitamin K antagonist and Novak. He is father of one of our own colleagues. Chat score, you look at the chat score, it's 6. Hasblood score is 6. Extremely high risk of stroke and extremely high risk of bleeding. And this is not an uncommon scenario because AF is the most common sustained clinical arrhythmia, 5-fold increased risk of stroke, and AF-related stroke has 70% disability. Vitamin K antagonist, you all know its demerits. Novaks came to solve this, but almost 30% of patients stop this drug at the end of 2 years. So what do you do with these patients? Play around with different Novaks or get behind the villain, which is the left atrial appendage. In 90% of non-valvular AF, the thrombus actually comes from the left atrial appendage. And for this person who is troubled by both AF and his episodes of neurovascular ischemia, we need to target both the arrhythmic risk as well as the left atrial appendage. So the patient was brought to the cath lab in normal sinus rhythm. The whole procedure was done under general anesthesia, transesophageal echo and intracardiac echo guidance. We have an esophageal temperature probe, right femoral 2 axes, one for 2 transeptals, a left femoral 10 front sheath, this is actually 10 front sheath left femoral put for the intracardiac echo. We have a locking sheath for the decapolar catheter because that's our anatomical reference for the 3D mapping. We have an invasive radial arterial pressure monitoring, and the whole procedure, we ensure that the ACT is between 350 to 400. So we take 2 ICE-guided transeptals. This is ICE showing the intraatrial septum being punctured and the protract wire getting into LA. We have 2 transeptals with an SLO and exchanging it to Agilis over protract wire. And this is the typical, most important step is the transeptal puncture. We need to have typically a postero-inferior puncture. So on your bicable view, you need to stay near the IVC, and on your short axis view, you need to stay away from the aorta. And first we do off with the arrhythmic thing. We make an LA map, do an RFA for the atrial fibrillation, do a circumferential pulmonary vein isolation. This is on the right side at 40 watts, 43 degrees, irrigated ablation, get the right sided pulmonary veins isolated, including a carinal line, then do the left side pulmonary vein isolation. You can see the circular catheter on the eyes going into the pulmonary vein. We can see the sharp pulmonary vein potentials disappearing and isolating, what Dr. Nambudiri said just before. So all the 4 pulmonary veins were isolated first, confirm that there's an entrance and exit block into the pulmonary veins, and given an adenosine to look for gaps. Did a flutter ablation as well because there was documented flutter. Again, these are standard procedures. And then we get behind the reduction of stroke. So we need to get behind the LA appendage, which needs to be closed. The most commonly studied device was Watchman. We have now a whole lot of gamut of devices which are available, both endocardial and epicardial closure. But we use Watchman which was the most studied device at that point of time. This is actually a nitinol frame with a PTFE membrane, which is available in sizes from 21 to 33. It's an intra-LA device with 10 fixation anchors. We have this sheath for the Watchman deployment, which is 14 French outer diameter and 12 French inner diameter, 75 centimeters in length. And this Watchman comes loaded, like your ASD comes loaded in a delivery sheath. And this is the animation on one side and what actually happens in the lab. So we take the transeptal axis, take this double curve sheet. This is the Watchman double curve sheet. This is the double curve sheet taken across the transeptal axis on a protract wire, which is your typical LAA wire. And we take in a pigtail to the left atrial appendage. You can see the pigtail going into the left atrial appendage. And we take in this catheter. The sizing is precisely based on TE. We actually measure the ostium of the left atrial appendage on the TE 0, 45, 90, and 135 degrees. And typically this is measured at the ostium about 2 centimeters from the tip of the limbus. The pathologist will tell you that no 2 LAAs are same. You find different anatomies, and whatever be the anatomy with the gamut of devices, we have any form of left atrial appendages, whatever working lengths they provide can be closed. It may be different anatomy, like it may be a windsock variety, a chicken wing variety, a broccoli variety, but all forms of these appendages can be closed. In our index case, the appendage was about 24 to 27 mm in the ostium, and the depth was 34. So we thought of taking a 30 mm device. So we take an appendogram in an ariocaudal view. This is an appendogram in ariocaudal view with the pigtail inside it. And the deployment is actually quite simple. It's a one-step deployment, and it can easily be recaptured and repositionable. So deployment, as you see here, it's on unsheathing. You take in the device till the left atrial appendage, this is the left atrial appendage, and you pull back the sheets, unsheathing and deployment. And once you've deployed the device, you ensure that it is stable. That requires 4 criteria, which is mnemonic as PASS, which is position, anchor, seal, and size. So first is position, that the device should be just distal to left atrial appendage ostium, that is marked by the left circumflex artery on the TE. Then is the anchor. So you do a tuck test. Like your ASD device, you pull the device and see whether it is staying in or not. The third thing is size. You measure the size of the device. It should be compressed at least 80 to 20% compared to the ostium of the size. So here we had almost 30% compression, which was okay. And this device, if you're not satisfied with the position, you can always recapture partially and redeploy. So this is a recapture of the device and then redeploying it in. The seal, which ensures that it's fully secured off, you can do on TE as well as you ensure that there is no leak, or if the leak is there, it is less than 5 mm. And on do an angiogram to ensure there is no flow into the left atrial appendage. Once all the 4 criteria are met, you just release the device in there, and that's it. The whole procedure is done. So this is the device released in the left atrial appendage, and the local hemostasis is achieved by a figure of 8 suture, as we do for any large size venous access. The post-procedure initially required warfarin or any of the NOACs for the first 45 days, then followed by dual antiplatelet for 6 months, and then aspirin long term. Now, this concept came because the endothelialization typically happens at the end of 45 days. Now, with the evolution registry, we know that we can even go away and do with a DAP for 3 months and then aspirin for 1 year. That should be sufficient. And Watchman is the most studied device because we have significant amount of data with Watchman. It has almost 98% implant success rate and only 3% complication rates. Majority of the complications have been around pericardial effusion, about 1 to 2%. Rest of the complications have been less. And the ability to discontinue NOAC due to a good LAC has almost been 96%. And if you have a residual leak, it can still be coiled, put in small other additional device, or put a small plug and get away with it. One concern which is upcoming is device-related thrombosis, which happens in about 2 in 395 patients which have been reported. Again, it happens in patients who have permanent AFib, very high CHAD score, very large LA diameters, and low ejection fraction. All these procedures, as showed, we conventionally do with TE, but can also be done with intracardiac echo guidance as well. And this is under Amulet, this under device Amulet, which is available with us now from Abbott. And this is the Lambre from LifeTech, which is also available with us. The people have run a cost-effective analysis and actually found, because this is a single-time procedure, they have found that one-time left atrial appendage closure runs to be more cost-effective than lifelong NOACs or warfarin. And currently, but still, because of the paucity of still data, currently the left atrial appendage closure still has a class 2B indication, probably because you really are not shown it superior to NOAC actually. The newer device is actually Watchman Flex, which is actually a rounded tip. So the Watchman Flex, on the contrary, has a rounded tip. So the Watchman Flex has a rounded tip, a closed ball, which so compared to the conventional Watchman, this is a rounded tip. So it actually is quite safer. It has 18 strut frames, dual precision anchor, and it has full ability to recapture and redeploy. So this was our index patient who was troubled by both atrial fibrillation and recurrent episodes of neurovascular ischemia, not tolerating any form of oral anticoagulant. He underwent a procedure with a Watchman appendage closure of the Watchman closure of the left atrial appendage with 30 mm Watchman under transesophageal echo and intracardiac echo guidance, and also underwent a concomitant AF ablation of all the four veins being isolated with RF ablation, again intracardiac echo guidance in a single procedure. It was gratifying for us because the first time this hybrid procedure, it's done some years back, the first time this hybrid procedure of AF ablation and Watchman closure was done in the whole of the country. And this was in fact the first Watchman implant of our stay. The procedure time average was about 3 hours. The duration of hospital stay was 2 days. He was discharged on day 2, and we have done a T at 6 weeks and 6 months for him. There was no intradevice leak, no intradevice thrombus. He's just on aspirin now and has had no episode of neurovascular ischemia after that, and is doing good on clinical follow-up. This was gratifying for me as well, because the whole procedure was proctored by my sister, and special thanks to her for this. And thanks again, KHRS, for the opportunity to present this. Thank you. Yeah, patient is in sinus. He had paroxysmal AF. He is occasionally having symptoms, but we are still not documented AFib after that. So he's still just on beta blocker, antiplatelet. He's doing okay on that.
Arun, beautiful demonstration. I have 2 questions. One, in the T, if we are seeing some clots in the LA, we have to wait.
Yes. Any form of these procedures, if you have a left atrial appendage clot, it's an absolute contraindication. So
Okay.
you anticoagulate, ensure that all the clot has gone before you instrument. If during the procedure you are finding that there's a clot forming, as one of the foreign operators showed yesterday, you might take a sheath in and suck these thrombus. But if you upfront find this thrombus, better not to dwell into LA, because procedural stroke would be catastrophic. This is a
Another-
preventive procedure.
Okay, another question is, in your case, the indication was intolerance to oral anticoagulations.
Yes.
So, suppose a patient is developing a stroke while on oral anticoagulation, is there any role in such patients?
Yeah, this is again we debated on. So the concept now is if a patient is on vitamin K antagonist and developing a stroke, most of the time the patient is not in a therapeutic INR, the TTR is not achieved in that way. In that case, the concept is to shift to a NOAC. And if the patient is already on NOAC, you then shift to a best NOAC that we have, which is dabigatran 150 mg BD or apixaban, which is the most safer of lot. If patient develops stroke on the best NOAC now, probably there's a role for a hybrid of combining a NOAC with a left atrial appendage closure. But there's a very few number of patients on this subset, but it's still into the recommendation that if patient has a stroke on NOAC, better to go for a left atrial appendage closure. Yes, per se, ablation of pulmonary, AF ablation or isolation of pulmonary veins per se does not give the physician the liberty to stop NOACs, but it definitely reduces the risk of stroke. Because sometimes people think that once you've ablated AFib, you can stop NOACs, but it's a misnomer. You should continue NOACs based on the chart score, but it definitely reduces the risk of stroke.
Is there any data on rheumatic AFs?
So no. There's a whole lot of difference in the pathogenesis of embolic strokes in valvular and non-valvular AF. In non-valvular AF, 90% of the time, the left atrial appendage is the culprit. In valvular AF, like rheumatic AF, only 60% of the time, the left atrial appendage is at fault. It's most of the time that clot happens from the body of the left atrium, and that is why left atrial appendage closure has not been done.
Arun Gopi, what is the present indication for hybrid procedure as you have done?
So now after this, it's quite commonly done. There's a lot of actually even some good volume of data from the Chinese group which have actually done this hybrid procedure, and they actually have this. So any person who is indicated for AFib ablation and is not tolerating anticoagulants becomes a class 1 indication.
The last question.
One practical issue is while doing hybrid procedure, the puncture site for appendage closure is posterior inferior, while for cryoablation you tend to do slightly more anterior.
To be frank, actually, see, once I understand your concept. Most of the time, in those cases, you go near the fossa itself. Don't go way posterior or way anterior. You go in the fossa. Go in the fossa slightly inferior. You would still get away with it.
It will not be an ideal puncture.
So we had an RF. So here we had an RF with a watchman, which is quite okay. You are thinking of a cryo with a watchman. You preferably go in the fossa, lower side, not much anterior posterior.
I had a problem because I tried through the same sheet to close the appendage and it applied.
Thank you. I think we had a wonderful session with two new techniques being demonstrated by two of the experts in the field. Thank you so much. We'll go to the next session.
Our next session is on unveiling the mystery of colors in 3D mapping. To chair the session, we invite Dr. Anand Martanda Pillai, Dr. Natarajan Kiyu, Dr. Praveen Srikumar, and Dr. Vivek Pillai onto the dais.
What about the chairpersons? So from a ice cold session, we now move to a colorful session.
Yes.
Okay, so we have 3D mapping based procedures, and to talk on the first topic, colors in 3D map, what do they represent? Very important topic, especially for those who are in the beginning stages of their career in doing 3D mapping based ablations. Over to you, Sabri Saravanan, who is one of the master technologists in the country in helping centers do 3D mapping based ablations.
Thank
So,
you.
over to you.
Thanks for the nice introduction. My slides, please. Yeah. Okay, so for the next 10 minutes, I'd like to talk about the colors in 3D map. What do they represent? I first like to good morning to all the respected doctors and allied professionals and my dear industry friends. And thanks to Dr. Nambudri sir and Vijay sir for this opportunity. So as my introduction, I am an Abbott employee. And coming back to the topic, what do colors means? Actually, it's whatever the system. If you see, it's all beginning with the rainbow colors. So you have a WebGR colors, and then followed by preceded by a white color in any of the 3D maps. So these are all the various 3D colors which you will be coming across in the maps. And in the next 10 minutes, I would like to explain how step by step you can able to understand these colors and what do they really represent. So before stepping on to the colors, we need to understand how the system is actually going to produce the colors in it. So first we need to do an activation map. That means you need to map a single beat of any of the tachycardia, whether it is a ventricular tachy or an atrial tachy. And we move the catheter to several locations, and that is called as a roving catheter. And we take how many milliseconds signals with respect to the reference. And these are all the inputs we have been giving it to the system. And if it is a 0 milliseconds, it is like an on time. And if it is an early with respect to the reference, the negative sign will be given. So it is a minus 50 milliseconds. If it is further earlier, it will be like a minus 100. And the system is automatically going to assign the color scale. The green color will starts with these 0 milliseconds. And then as it goes earlier, so it will become like an orange, yellow, red, and white is the earliest. And when it goes later, so it will become like a green, light blue, dark blue, purple colors. So this is what actually the system is doing. So whatever the inputs we are providing it to the system, and it is going to assign the colors accordingly with respect to the reference what we are going to map. So as I told that in this screen, like you have moving the catheter, which is to the different locations, and you have taken a reference as an atrial arrhythmia. This is the atrial electrogram as a reference, and we are moving the catheter to different location and annotating the points, taking the activation points. In this 3D maps, whatever the dots, that is the yellow dots you are seeing, so those are all the activation points which has been collected, and based upon the activation timing, the system is going to allocate the colors over there. How to read these colors? Always go with this color pattern which is there as a reference in all these 3D screen. So the earliest over here is the red, white color, and then the next early is the red, then orange, yellow, green, blue, and purple. So if you start off over here, it looks like a pattern of a centrifugal pattern. So it all starts off from this white and then followed by the red and orange, yellow in all the directions. So this is called a centrifugal activation pattern. If you get a map like this, then this arrhythmia is called as a, you can term it as a focal arrhythmia from that area. So this is how the focal activation map looks. And this is the focal activation map of a ventricular arrhythmia. So again, the same thing, if you look at the 3D maps with any of the colors, go with the activation pattern. So, and if the colors are, and trace the colors like a white, red, orange, yellow. So if you have a white followed by a red, orange, yellow, so you will have this again is a focal tachycardia, which is arising from the white area, small area. So this is called a centrifugal activation pattern. So when it comes to the re-entry, you forget about this is a re-entry tachycardia. You just follow the rules by going with the colors. So of the tracing, so white, the white starts over here and then followed by red, orange, yellow, green, blue, and purple. So the white is coming back and meeting the purple is meeting the white. So this is called the re-entry activation pattern. And for example, this tachycardia flutter cycle length is 250 milliseconds. So you can go with this color bar wherein the color bar is mentioned as the LAT timing. So the LAT timing is like, starts off with 150. So the white is assigned as 150 milliseconds, then followed by orange, 100 milliseconds, early 50 milliseconds, early 0 milliseconds, and plus 25, plus 50, and plus 100. So if you calculate that white, the colors of, all the colors, all the tachycardia cycle length has been covered in this one atrium, and it occupies more than 90% of the cycle length. That means this is a reentrant tachycardia which is coming from the chamber what we have mapped. And if you follow the color pattern, it tells you in which direction it is moving. The circuit is moving in the anti-clockwise direction. So this is the typical atrial flutter. And when it comes to whichever the atrium channel is, this is a left atrial tachycardia. So now you have the color coded map here. So you can just follow the same pattern, look at this, whether it is an activation map or not. So that will be taken care by the by the left-sided window. So you follow the color pattern: white, red, orange, yellow, green, blue, purple. So it's an early meeting late pattern. So it is a flutter which is going around the mitral annulus in the clockwise direction. That's what it says. So we have seen the focal arrhythmia and then the reentrant tachycardia. So what else the colors can actually make? In the recent times, we know the colors do represent many other aspects. So when you are mapping the right atrium, and for this example here, the septal area of the right atrium is having a wide area of the early. So you can say that this is a focal because you are coming it from here, from the septum. But if you see that it's not a centrifugal pattern because the wide area is the early in the septum. So there may be a likely chances that it tells that the arrhythmia can be arising from any other nearby chamber. For example, here it is a right atrium, so it can be arising from the left atrium and then exiting into the right atrium in the septal area. So obviously we need to go and map the left atrium. Once we map the left atrium, you will have this is called a centrifugal pattern. The white area should be minimal, then followed by all the colors. So that's what it is. So it is coming from the right superior pulmonary vein. So if you get a wide area of early in any of the chamber, so it actually tells you that the arrhythmia is coming from the nearby chamber which you need to map. And what else the color can tell? So the color can represent many other things like conduction velocity. So if you have a color like this, a single color of blue color which is having a covering a large area, and then this light green color is covering a small area. So what it means actually? For example, in this map, the tachycardia cycle length what we mapped is 400 milliseconds. All the colors are there. So white, red, orange, yellow, green, blue, purple, all the colors are there. So the total number of colors is 7. So each colors represents 57 milliseconds. So 400 divided by 7 is 57 milliseconds. So long distance covered in 57 milliseconds versus the short distance covered in 57 milliseconds. That means what? This blue color is taking a long distance, but it is covered faster. And this light green color is still smaller distance which is covered in 57 milliseconds. That means it is taking a shorter time. It is taking a long time to cover this short distance. This is taking a short time to cover the long distance. So this is faster pathway and this is the slower conduction zone. So then you are identifying the circuit. So the circuit is going via this way, and then if you are finding more colors in the small area, for example, I'm moving my mouse over here. So in this area you are having a white, red, orange, yellow. So you're having 4 colors over there in the small area. That means it's isochronal clouding. So that means what? It is like 57 milliseconds multiplied by 4. That means 228 milliseconds is covered in this, which is more than 50% of tachycardia cycle. And so that is the area of slow conduction, and those areas are going to be the critical isthmus in our conduction in this flutter circuit. And there is another concept which is called as functional line of block. That means what? If you see a sudden jump in any of the color pattern, then that line is a functional line of block. How it helps in understanding the circuit, and more importantly, it helps us to choose the target line of ablation. So always whatever the map is, go by this color over here. So you have a white, red, orange, yellow, green, blue, purple. So it is going around the re-entry here. So what is happening in between that? So in between that, so you have a purple color, then below that you have a red color. You have blue color, you have orange color. So that means there is a sudden jump in the color in between. That means the wavefront is not coming from top to bottom in this area, nor it is coming from bottom to top. So then this area is called as a functional line of block. So why it is very important? We know that it is going around this functional line of block, and you have the pulmonary vein which is already isolated, or there is no signal. So if you draw a line from the pulmonary veins to this functional line of block, will take care of this flutter. So it's the flutter is not only a atrial flutter. The ventricular tachycardias can also be a re-entry in terms of scar related stuff. So this is one of the case, and you can analyze it's a focal or re-entry first. So obviously it is a re-entry. So you have a re-entry around this, and then you are having a color clouding over here, and then you are having a line of blocks. So now we know that it is going around the mitral annulus in the clockwise direction. And again, quickly moving to the scar map. The scar map is nothing but same thing. You move the catheter to the multiple locations, and the system is going to record how much is the voltages in this particular locations, and system is assigning the color for that. The scar map is, the voltages are measured in the millivolt area. And if you see the blue or purple color, it is all the healthy zone. And if you see a gray color area, so it all will be a scar, and in between the gray color and the purple areas are your border zone areas. So that's what a scar map tells you. So whatever the map is, if you see the pattern over here, if it is in millivolt, then it is dealing with the scar map. If it is in milliseconds, then you are dealing with the activation map. So I quickly conclude, colors mean everything, and it makes sense in understanding the arrhythmia mechanism, circuit, and strategize the ablations, provided if we are doing the activation map properly. There are many factors which influences the colors in the activation map. For example, your reference, your window setting, mapping catheter stability, mapping catheter contact with the chamber, and you need to map the entire chamber, and whether there is a noise or artifacts in the EP lab, and your mapper skill, and then the clear communication between the EP doctor and the mapper. So it all matters, which all the factors influence the colors in any of the activation map. And colors mean nothing if our activation mapping or points are incorrect. That means a system provides the output from data, what we are providing it as input. If you are giving in the garbage, so only the garbage will come out. If you give a actual proper input, so we will get a good quality of map. Thank you so much. Thanks for the opportunity.
Thanks, nice talk. One thing, we can do a voltage scanning also. Like if you do a scar map and you can change the voltage and you can see a different voltage areas. So you can, just by scanning, you will get an idea of how the scar is.
Yes.
And then you can decide on further high dense mapping.
Yeah, yes. You can start off with the 0.5 as a cutoff for scar, and you keep coming down, scroll down. Once you start getting the channel, so we will get the channels inside the scar.
See, what people don't really know is that, see, the color mapping is there in everything. Whether you take the wind velocity or whether you take the rains, or everything is basically the same WebGR component.
Yes.
For a non-EP person, initially it looks challenging, but it is not, as long as you understood, and this made very clear. A very good talk.
Thank you, sir.
Tips and tricks for localization and ablation of focal VT or PVC. Dr. Ajit will be talking.
Good morning, everybody. So without wasting time, let's go to the talk. I'll just stick to a few basic principles that one should keep in mind. Most of the idiopathic PVCs or focal PVCs and VT come from the outflow tract. So it's imperative that you must be very clear about mapping and ablation of outflow tract PVCs. After the outflow tract, the most common sites are the left ventricular fascicles and the papillary muscles, and then some uncommon sites. So if you get the first two right, that will cover most of it. Now, the hallmark of outflow tract PVCs or NSVTs are 2, 3 and AVF are positive. So the first thing you look for in the ECGs are 2, 3 AVF and positive. Supposing you have a patient with an anterior wall MI or a lateral wall MI and you get these PVCs, please understand that the PVCs got nothing to do with the MI. No, you can have an idiopathic PVC in a structurally abnormal heart. So it's very important to look at the morphology of the PVC. Left ventricular PVCs will be positive in V1 if they're coming from not the outflow tract part of the left ventricle, but from the cavity of the left ventricle, because left ventricle is the posterior ventricle and V1 will be positive. So within the left ventricle, we have these. We have the papillary muscle, the anterolateral papillary muscle and the anterolateral fascicle. They are close to each other. The axis will be aligned towards lead 3. That's all you need to understand. The axis will be aligned towards lead 3. Here the axis is aligned towards lead 3. Whereas if it's a posteromedial papillary muscle or the posteromedial fascicle, the axis will be superior. The axis will be away from lead 3. Lead 3 will be maximally negative. Between papillary muscle and fascicle, it's a little tough to differentiate, because the fascicles often insert into the papillary muscle. So you could have a PVC which is actually starting in the fascicle but exiting into the papillary muscle. It look like a papillary muscle. So don't be 100% sure by looking at the morphology that it is a papillary muscle or a fascicle. But the general point is that if you have a classic right bundle branch block pattern, RSR dash, and a sharp initial R in V1, it is likely to be from the fascicle. The converse is not always true. If you have a R dash or a slurred R in V1, it may be coming from the papillary muscle, or it may be the insertion point of the fascicle into the papillary muscle. The last part, the RV moderator band, I'm not going to talk about. It's not all that important. It's not all that common. Just understand one thing though. If you have a PVC or a VT which looks like your sinus QRS, and it has a 2-3 discordance, lead 2 positive, lead 3 negative. This means it is coming from very close to the His bundle. So, you try a little bit more with medical therapy before you're considering ablation with that. So just understand that thing. 2-3 discordance and a transition, precardial transition, which looks similar to a sinus QRS. This is coming from the parahisian area. So other than the papillary muscles and the fascicles and the outflow tract, this is all you need to understand. Now let's go a little bit more in detail into the outflow tract. You must know that the posterior part of the right ventricular outflow tract overlaps the aortic cusps. This is very important to understand. So this is the dissection of that. Why? Because most of the PVCs exit from where they start. Meaning, if you have a morphology, with the morphology you can more or less pinpoint to anterior outflow tract, posterior outflow tract, or septum between posterior outflow tract and cusp, or the anterior cusp, the left and the right anterior cusp, or the posterior cusp, the non-coronary cusp, or more posterior to that. More posterior that would be the mitral annulus. So looking at V1 and V3, you can more or less pinpoint to these, and it is mostly accurate, but sometimes it might start from the middle here and decide to exit out somewhere else, or vice versa. It might start from here and decide to exit out here. So the localization is not perfect, but it's more or less, it gives you an idea where to start mapping. So it's important to understand this. Now, what do we look for? Look only at 2 features in the ECG. Don't look at too many things. The more anterior you are, the more negative V1. That's fairly straightforward because V1 is anterior. So the anterior most RVOT are likely to have the most negative V1. You get the posterior part of the RVOT, the septal part of the RVOT, V1 is going to have a small R wave there. You get even more posterior into the coronary cusp. You'll have a broader R wave, not necessarily a taller R wave. Look at number 3, a broader R wave in V1 once you get to the coronary cusp. And once you get to the posterior part of the coronary cusp, that's the non-coronary cusp, you'll have a tall and broad R wave. And once you get even more posterior to the coronary cusp, that is, you get to the mitral annulus, the V1 becomes almost fully positive. So just understand this thing about V1 to know where, as you move from anterior to posterior. These are just rough principles to let you know where to start. The second thing which you need to look at is V3 transition. That is it transitioning from negative? So the ones that start with a predominant negative in V1, is it transitioning from negative to positive at V3 or after V3? If it is negative beyond V3, that is V1 to V4 are negative, it's almost always RVOT free wall. But if your transition is at V3, you're not sure if it is RVOT septum or posterior to the RVOT septum. So just look at those 2 things, V1 and whether it is transitioning at V3 or beyond V3. Beyond V3 free wall, at V3 you're not sure if it is septum or posterior to the RVOT septum. That's a cusp. And here's the fluoroscopic correlates of what I told. If you looked at it, the RVOT would correspond to so this is in the pulmonary artery. So it goes above the coronary cusp. It corresponds to the pulmonary artery corresponds to the left main coronary artery. Whereas so here is again an example of how the pulmonary artery would correspond to the left main coronary. So if you have something which comes from above the left main, you might, and it is, the mapping suggests that it's intramural, you might actually resort to bipolar ablation from above the left main plus the RVOT. So these are just some fluoroscopic correlates. So if you look at the cusp between the non-coronary cusp and the left coronary cusp, the commissure between the two cusps, this is what your catheter would look like. And if you looked at the non-coronary cusp, that would be the really posterior cusp. This is what it will look like in RIO. This is what it will look like in LAO, just to give you an idea what this. And if you go to the other end, the anterior-most RVOT, the anterior-most RVOT will overlap the junction of the great cardiac vein and the anterior interventricular vein. So if you have an epicardial focus from the GCV AAV junction, easier way of getting it would be to ablate through and through from the anterior RVOT. So that is the anatomical localization. Now coming to the electrogram, this is more important than that. Now the intracardiac deflection starts about 15 to 50 milliseconds before the QRS, because it takes, you need to activate that much amount of critical muscle before a surface QRS is recorded. But the intracardiac deflection will start early. So the thing is just to look at an early intracardiac deflection or a pre-potential. Sometimes there will be isolated bits of tissue which generate a pre-potential. But the devil is in the details. So to start with the earliest clearly visible QRS, in here the earliest clearly visible onset is in V3, and look that as a reference, take that as a reference and look closely at ablation distal bipolar, ablation proximal bipolar, ablation 1 unipolar and ablation 2 unipolar. EGMs do not lie. Like Shabri said, you put garbage in, you get garbage out. So you look at the EGMs very closely before you annotating on your 3D map. So here, the ablation distal is early, but look at the configuration. This is very low frequency compared to this part. This is high frequency. So this is a far field, meaning it is recording from a tissue, not a tissue which you're touching, but farther from the tissue. Remember, low frequencies travel a longer distance. High frequencies travel only a short distance. So you want an early electrogram, but not an early far field electrogram. And you don't really want the unipolar to have an isoelectric like this. So this is what you would prefer. You need an early near field electrogram. You see the early part is now higher frequency, and with this, even if the unipolar is Q, it's okay. Even if the unipolar is isoelectric, it's okay. What you want in the unipolar is you do not want an R. You want ideally a steep Q, but if you don't have a steep Q, it's okay. Even if you have isoelectric, it's okay, so long as the bipolar is near field and early. But this is not at all good. You see, the distal is earlier, the proximal, this is the proximal, which is earlier than distal. And you look at unipolar 1, the slope is very poor. The unipolar 1 has a shallow slope, whereas unipolar 2 has a steeper slope. So this is closer to unipolar 2 than unipolar 1. So this is much better. The distal has a near field. The distal is earlier than proximal. And you look at the slope of unipolar 1 and unipolar 2, the unipolar 1 has a very steep slope, whereas unipolar 2 has a shallow slope. So it's under unipolar 1 than unipolar 2. And this is better than an early local deflection, a pre-potential, though it's often not clearly visible. That is would be better than an early local deflection. And finally, you might rarely get this finding. Don't miss it if you get it. You look at the polarity of the bipolar electrogram in ablation distal. I would actually look at distal 2-3 and proximal. You see there is a polarity reversal in the local bipolar electrogram and distal and 2-3. This means that, and you can see that in 2, you can see that deflection in 2, but not in 1. What does it mean? This means this is between electrode 1 and electrode 2. So if you get that finding, then you have very precisely localized it. So the role of 3D is just to anatomically tag what you've got. Don't believe the signals in 3D. So once you tag it in 3D, look at the signal that gave rise to it. This is the signal that gave rise to this point. Then I always use the software called Direxi. To me, that's the most important thing, because you click this signal and then it will take you to the 3D point of that signal, and automatically it will take you to the 2D electrogram at that signal. Then you verify with the 2D electrogram to make sure that what you're seeing is not garbage. Ablation activation versus space mapping, as far as possible, I'll do only activation mapping. I know that you can get a perfect base map with current algorithms, but the results of activation mapping are definitely better. But the key is to try and select patients who will have frequent enough PVCs or NSVT, And usually what I do is I do a 12 lead Holter in the 1 week prior to ablation. If it's frequent enough in 1 week prior to ablation, generally if you're lucky, it will be frequent enough during the procedure also. So I hope I outlined the very basic principles of mapping a focal PVC or a focal NSVT. Thank you.
Excellent talk, Dr. Ajit. You told in the conclusion slide, sometimes we see that a patient is very symptomatic. The previous day there are multiple VPCs. On the day of the procedure, unfortunately, the VPCs become very infrequent. Any tricks for that particular situation?
Yeah, I look at 2-3 things. In addition to the frequency of the PVCs, I also look at whether the PVCs come during sleep or the PVCs come during activity. If the PVCs come during activity, a tiny dose of isoprenoline might induce a PVC. Whereas if PVCs come during sleep, actually a small dose of phenylephrine brings it out. It sort of makes physiological sense because phenylephrine causes it works out. Give 0.1 microgram to 0.5 microgram bolus of phenylephrine, one vial diluted in 100 ml of NS, and the PVCs that come during sleep seem to come out with phenylephrine. The other thing is make the patient really comfortable. It is extremely important to make the patient very comfortable. The moment the patient is tense, sinus rates increase and the PVC doesn't come. So 2-3 things: talk to the patient, calm the patient down the moment this patient is taken into the lab. Do not sedate the patient. Minimize the amount of local anesthesia that is infiltrated in the groin around the place. I still believe that it can get absorbed and suppress the PVCs. But very important thing is to have a very relaxed patient. And if you take a PVC patient for PVC ablation, please don't put the patient in the lab and go after half an hour after the patient is draped. Now, be in the lab at the moment of draping. We all do that. We tell them take the case, and then in that time we are busy. We are taking around, seeing something else, and half an hour after the patient is draped, we go in. By the time the patient is already anxious, PVC is gone. So be in the lab at the moment the patient is taken into the lab. Talk to the patient, keep the patient comfortable from the moment of draping onwards. Do not waste any time. So I read a very beautiful paper saying that the most important factor that determines success of PVC ablation is a number of PVCs in the first 15 minutes of mapping. After that, everybody is tense, patient is tense, sinus rate is too high, no more PVCs.
This experience of this local anesthesia suppressing is very bitter, and I have had at least couple of cases where.
So I do not give more than 7 cc of local for PVC thing, and I minimize the number of sheets, and I do not put a large arterial sheet because they all demand large amounts of local anesthesia.
Caffeine, is it available in India? Deepak Padmanabhan used to tell that IV caffeine is available. Do you have
Aminophylline, we have tried aminophylline. Caffeine I have not tried. I don't know
Praveen was talking about Red Bull.
One patient, he knows. One patient we gave Red Bull.
We have actually done that in.
There was no PVC, nothing. We gave atropine, aminophylline IV, many things, and nothing came out. We asked the patient to get up. Nothing happened. One child, she's 18-year-old. Finally, we gave Red Bull one.
Yeah, we have given Coke. We're not given Red Bull, but we have given Coke.
What did the Red Bull do?
Yeah, we asked the patient what brings it out. He says, whenever I drink a fizzy drink like Coke, it said. So, okay, get a Coke. We got a Coke, gave it to the patient, and to be honest, it came out. I don't know if it was psychological or not, but ask the patient what brings it out in real life.
You can as well advise not to have Coke in the first place. Thank you, Dr. Ajit, for the nice talk.
I had a slide on that. Yes, you can do the same. You use the same principle for VF ablation if you can get the triggering Purkinje potential. I didn't put that slide there because of this reason.
Anyway, thanks, Ajit, for the nice talk. So we go to the last talk of this session. We are almost 1.5 hours behind schedule. Like EP procedures being very unpredictable. Lot of times you overshoot time. So is EP conference also. So we'll have the last talk on mapping and ablation of re-entrant atrial tachyarrhythmia by Bhima Shankar. Yeah.
Thank you. Good afternoon to everybody. The task in hand is to give you an overview of mapping and ablation of re-entrant atrial arrhythmias. What I've done is structured into this order in the next 10 minutes. It's imperative that we have an idea, lead of what arrhythmia we are managing in the lab before embarking on extensive mapping. So how do we establish if re-entry is a mechanism or is some other non-re-entrant mechanism? We'll try and see how we can do that. Then we look into the categories of atrial reentrant arrhythmias and the typical workflow in the lab. The second part would be utility of electroanatomic mapping and its pitfalls. Mr. Sabri has made my job easy there. He was saying one of the pitfalls is not having a sync between the mapper and the ablator. I thought you said that. And then we look into how we identify the critical isthmus in a color map. And then finally, we'll finish off with lesion sets that we do to transect the circuits both in CTA-dependent flutter and non-CTA-dependent flutters, primarily LA flutters. So technically, mechanistically, macro reentrant arrhythmia is defined. It's a large circuit around a obstacle, inert, electrically inert obstacle. Either could be anatomical or it could be a functional structure that's causing a reentry. So in the ECGs of macro reentrant, you'll have undulations and you don't have an isoelectric line, unlike a focal atrial tachycardia. However, this is not the case in all macro atrial tachycardias. If you have a large disease atria and large scars in the atria, you still can have isoelectric lines. So that has to be kept in mind. So this lead has to be taken from the ECG. And in the EP lab, before you start mapping with your EAM maps, the activation sequence when we idea from the multipolar electrode that you put in, either the decapolar, duodecapolar, or the halo, you have an idea from whether it is a macro reentrant tachycardia or a focal atrial tachycardia. Like the endocardial recordings typically show activation spanning the entire tachycardia cycle length. More than 15% variability in tachycardia cycle length actually points towards focal atrial tachycardia. And the key in macro reentrant atrial tachycardia is entrainment mapping. Yesterday, Dr. Anish was elegant on describing what entrainment is about. And this is very important for distinguishing the mechanism and to decide whether it is macro reentrant tachycardia or a focal atrial tachycardia. The micro reentrant atrial tachycardia can be confusing in this scenario and has to, although can be captured only when you're entraining from close to the foci. And again, if you can actually entrain from two sides that are at least 2 centimeters apart, with characteristic of being in the circuit, meaning that your PPI is very close, then it is a definition for a macro reentry. Again, response to adenosine can be of use if focal atrial tachycardia tends to respond to adenosine either by termination or slowing. Focal can again be confusing in this scenario. So we'll move on to the categories of macro atrial arrhythmias. The prototype reentrant atrial flutter is the CTI dependent flutter, which could be either clockwise or counterclockwise. And the lower loop atrial flutter is also CTI dependent. And this can most often be in de novo, and this is the prototype to understand what macro reentrant tachycardias are. To classify macro atrial tachycardias, we can classify them as CTI dependent and non-CTI dependent. This has implications both for therapy and your outcomes of ablation. You can further classify them as de novo macro atrial tachycardias or post-atrial surgeries. Now we have the third classification, and probably in the West, that's the largest number of macro reentrant atrial arrhythmias that are doing after AFib ablations. They kind of set in a lot of atrial arrhythmias in the left atrium. So here you have upper loop reentry, which can be de novo, and you have post-atriotomy scar flutters that go around the atrial scar. You can, in LA, by far, the de novo flutter is a mitral annular flutter, and most often these patients do have significant scarring, primarily in the posterior LA. You can also have circuits around the pulmonary vein antrum, and then post-surgical cases again are either post-AFib ablations or usually roof-dependent atrial arrhythmias. This paper, I brought it up. This is an old paper, almost 20 years old. This is the first of the paper that actually looked into de novo patients. This is from Bordeaux, a center that was doing a lot of AFib ablations, but they looked into their first 22 cases of LA flutter, and vast majority of them were mitral annular flutters, and as significant of them actually had a scar in the posterior atrial wall. So how do we what's a typical workflow in the lab? First is to establish whether our mechanism of the arrhythmia that we're dealing is reentrant or non-reentrant, and then see if it's CTI dependent or non-CTI dependent. This again has implications of your ablation success. Once that is established, you once put in your catheters, your multipolar catheters like the duodeca, deca, or the halo catheter, you try and look at the activation pattern. The activation pattern in the duodeca and the CS catheters will give you a lead in which chamber your arrhythmia is located. And also should be always be combined with entrainment and limited entrainment. There could be a small difference in school of thought. Some of the operators think that entraining would actually terminate the tachy or alter the tachycardia to some other flutter, but a limited entrainment would actually help focusing our 3D mapping to the chamber that is of interest. And then once you find out the chamber of interest, then you take up your 3D mapping system. Today, high density mapping is almost becoming a standard of care. This should always be complemented with entrainment. This will give us the substrate, the scar patterns of the atrium, and also help us localize the isthmus, its location, its dimension. And then once you do that, you try and transect the circuit, preferably it's irrigated catheter in the LA and in non-CTA dependent. And if possible, if there's no financial crunch, it's still good to use even in CTA dependent flutters. And using contact force and steerable sheets helps and improves your success rate in the lab. This is just I put up to show you that once you put in your, even before you initiate your 3D mapping systems, once you put in your multipolar catheters, you know that the activation span of your almost 70% of the cycle length is almost the halo showing most of your activation in the RA, and the CS activation pattern is proximal to distal. This kind of narrows down to the chamber is RA, but this is anywhere pattern recognition. This is for a counterclockwise flutter. The same can be done for other chambers, and that will help us localize. So when we take up our electroanatomic mapping systems, today, earlier we were mostly into bipolar. Today, most centers are using multi-electrode mappings and high-density mapping. It's sequential mapping of activation pattern, which and then this helps you understand the substrate and the voltage. The voltage lets you understand the substrate. The EA map gives you a lot of information, and this need not be taken in face value. Like Ms. Sabri said, it has to be taken combining with your basic E-grams entrainment. So a couple of critical issues that needs to be understood is one, you need to choose for atrial flutter, you need to choose an unambiguous, uncorrupted, stable reference. Usually it is the CS bipole, one of the CS bipole that's taken. And annotation, in the past, when we were using the conventional bipole mapping systems, annotation was an issue. So oftentimes when the map is untenable, you actually do some post-processing and then re-annotate your point. But with this high density mapping, the system has autocorrect systems where your annotation is not an issue. Window of interest, I'll spend a slide on it, although Sabri had actually went in depth of it. Interpolation again is not an issue when you're using high density mapping. When there is a variation tachycardia cycle, which can happen in primarily LA flutters, then you need to remap or have mechanisms to understand that you need to have cognizant of this thing that can happen. I'll spend a while on window of interest. Conventionally, what we do for window of interest is to choose a stable electrogram, and 95% of the cycle length is what is chosen for the window of interest. And once it's usually a symmetrical window, you take 50% before the chosen electrogram and 50% after the chosen electrogram. And colors in macroatrial flutter does not mean that you're focusing on the isthmus. You get this pattern called early meets late, and it all just tells you that's a re-entry pattern, and that does not actually correspond to the isthmus. Like for this example, when I choose a CS proximal electrogram as a reference, the red point, the closest ones will be marked red, and then on you can get your different colors, which somebody had already alluded to. But this again can be shifted. If I choose a reference point elsewhere, the early meet late will be at another point, and therefore early meet, the connotation is just that it's a macroorient tachycardia and nothing else. By chance, the early meet late can actually coincide with your isthmus, but that need not necessarily happen. There is this elegant paper from De Ponte that was published in 2007. How do we see that your early meet point and the isthmus coincide is to use the surface EZ to choose your window of interest. You can, in macroorient flutters and LA flutters, primarily when they have large scars, you tend to have these isoelectric basic lines, and if you choose it diastole and then choose your window based on diastole to diastole and then choose your window, your early meet late point may correspond to the, most often corresponds to the early meet late point, the isthmus. I put this up to tell you that annotation can be an issue in the times when we're using bipoles. So in scenarios like that, you can actually take location only and then do post-processing. These are pitfalls that we need to do and not go by face value of the map that we're taking. Today, high density maps almost 14,000 odd points. So interpolation is not an issue anymore. Isochronal crowding, again, he had pointed out the simple concept, he went on in depth, but the simple concept that a putative isthmus will have large part of the cycle length. So therefore, that site will have isochronal crowding, and that will actually lead you to the potential isthmus where we can use for transecting. This again is showing isochronal maps in a Carter map where incidentally the early meet late is coinciding with the isthmus. I'll finish off with the flutter lines. For typical flutter, we all know we use the central isthmus, which transecting from the tricuspid annulus to the IVC. In India, oftentimes for financial constraints, this can be done without 3D mapping, especially if the atria is normal size. And in the scenarios where you have issues like prominent pouches, thick isthmus, you may have to resort to irrigated tip and use 3D mapping system. Typical target in macro in flutter is to transect or connect an anatomical inert structure to another anatomical electrically inert structure so that you transect the circuit. Like for an atriotomy scar, the line should be from the scar to the SVC. In LA, there are several lines that can be like for a mitral annular flutter, you try and connect. The most commonly done mitral isthmus line is from the mitral annulus to the LS left LIPV line. So this I took it from again from the 2000 paper. They actually use several lines to transect mitral annular flutter, but the easiest would be, the shortest would be the LIPV to the mitral annulus. I'll finish off with some takeaways. So activation mapping and entrainment remain the key tool of tackling reentrant arrhythmias of the atrium. Electroanatomic mapping and high density mapping complement has incremental benefit in tackling these complex circuits. It's important to have a grasp of the nuances and understand the limitation of EAM. That's essential while we do these macro-atrial arrhythmias. Thank you.
Nice talk. One other thing. Do you use DePonte method routinely or PN to PN?
No, I have not done that. Not any numbers to do that, but I heard from friends, at least in centers, they prefer that. So
DePontes.
DePontes.
But there are studies which says PN to PN also is quite
P to
okay. PN to PN.
I understand.
So, I think we'll close this. So thank you. If there are no questions.